Good day, dear colleagues and everyone dedicated to the fight against cancer. It's a great pleasure and honor to participate in this amazing event. I would like to sincerely apologize for not being able to join you live today. I'm grateful for the opportunity to share the pathologist perspective through this pre-recorded presentation on how to diagnose and treat gallbladder and bile duct cancer. Before I begin, I would like to state that I have no disclosures. I would also like to mention that some illustrations in this presentation are AI generated and are used for scientific and educational purposes. Today I will talk about cholangiocarcinoma, a malignant epithelial tumor arising from the biliary epithelium of the bile duct and gallbladder, and more importantly, about how modern pathology contributes not only to its diagnosis but also to treatment decisions. Cholangiocarcinoma is the second most common primary liver malignancy and remains one of the most aggressive tumors of the hepatobiliary system. Despite major advances in imaging and clinical management, the definitive diagnosis still depends on pathological examination. What we see under the microscope directly influences how the tumor is classified, how aggressive it is expected to behave, and increasingly which therapy the patient may receive. In other words, pathology has become a key element of personalized cancer care. The diagnosis of cholangiocarcinoma is no longer based on morphology alone. It's a multimodal process that integrates classical histology with immunohistochemistry, molecular analysis, and more recently digital pathology and artificial intelligence. It may be an iteration, but worth to mention once again that depending on anatomical location in the biliary tree, a distinction is made between intrahepatic cholangiocarcinoma, developed from the intrahepatic bile ducts beyond the second segmentation, perihilar cholangiocarcinoma, developed at the level of the right and left hepatic ducts, their junction and the hepatic duct, and the distal cholangiocarcinoma, developed at the expanse of the common bile duct. The last two subtypes fall into the category of extrahepatic cholangiocarcinomas, according to the last WHO classification of digestive tumors. Traditional evaluation for pathologists begins with macroscopy or gross anatomical examination of tumors. Macroscopic classification, developed in 1992 by the Liver Study Group of Japan, is based on tumor growth criteria and accounts for tumor biology and patient prognosis. This classification correlates closely with radiological characteristics and describes three main types of cholangiocarcinoma, whether intra or extrahepatic: mass-forming, periductal infiltrating, and intraductal growth. Thus, these macroscopic types present specific features, in particular microscopic ones, and are observed differentially along the biliary tree. The mass-forming type is defined by a well-limited rounded intraparenchymal mass. These tumors are usually firm, whitish, and polylobed without a capsule. This type is mostly seen in small duct intrahepatic cholangiocarcinoma. The main mass, usually large, mean size with 10 cm, is frequently accompanied by centimetric satellite tumor nodules, considered as intrahepatic metastasis. The second one is periductal infiltrating type, which is characterized by tumor extension which infiltrates the biliary wall, producing a diffuse whitish parietal thickening. This tumor most often causes a stenosis or an obstruction of the bile duct, and is then responsible for a dilation of the bile ducts upstream of the obstruction. This type of tumor has a poor prognosis. The third one is intraductal growth type, which refers to a tumorous proliferation developing in the lumen of the bile ducts. It is most often revealed at an early stage, while the tumor remains localized, polypoid, and limited to the mucosa, invading the biliary wall only in the later stages. In some cases, the tumor is multifocal, involving different segments of the biliary tree and producing a picture of biliary papillomatosis. This tumor type has the best prognosis among the three: mass-forming and periductal infiltrating. Most cholangiocarcinomas, more than 90%, whether they macroscopic type, correspond to adenocarcinoma of various differentiation. They present a predominantly glandular pattern in the mass-forming and periductal infiltrating types, and a papillary pattern in the intraductal growth type. Cholangiocarcinomas are characterized by the presence of an abundant fibrous stroma, usually with no or little inflammation, harboring numerous blood capillaries. The degree of tumor differentiation is based on the proportion of glandular and papillary structures within the tumor proliferation, as well as on cytological criteria. According to CAP protocols, for adenocarcinomas, a quantitative grading system based on the proportion of gland formation in the tumor is suggested, as shown below, and thus we can have grade X when grade cannot be assessed, grade 1 with well differentiated, grade 2 or moderately differentiated, and grade 3 for poorly differentiated cancers. And signature cell carcinomas are assigned as grade 3. Depending on histology, intrahepatic cholangiocarcinomas has two main subtypes, depending on the level or size of the bile duct involvement. The small duct type derives from the intrahepatic small bile ducts, like Herring's ducts, bile canaliculus, bile ductus, and intralobular bile ducts. So, intrahepatic cholangiocarcinomas are adenocarcinomas with small tubules lined by cuboidal cells or with acinar structures, and they infiltrate the hepatic parenchyma. The small duct type most often presents as a mass-forming macroscopical variant. The large duct type intrahepatic cholangiocarcinoma develops at the extent of large intrahepatic duct, second segmentation, or from peribiliary glands. These are adenocarcinomas arranged in the large ducts or papilla lined by mucus-secreting columnar cells with aspects of invasion of the duct wall and hepatic parenchyma. The large duct type is usually the periductal infiltrating type and less commonly infiltrative growth type. Perihilar and distal cholangiocarcinomas, macroscopically and histologically, are similar to large duct type of intrahepatic cholangiocarcinomas. They are mainly of the periductal infiltrating type and less commonly intraductal growth type. Usually they present as poorly circumscribed scleronodular tumors or less frequently as an intraductal papillary tumor. The vast majority are conventional mucus-secreting adenocarcinomas. They derive from mucus-secreting columnar cholangiocytes or peribiliary gland cells, which are also involved in the origin of preneoplastic lesions. In this picture, moderately differentiated adenocarcinoma is seen, with cancer cells with intestinal-type features arranged in a complex tubular papillary architecture. While morphology remains the foundation of diagnosis, immunohistochemistry provides essential additional information. Among epithelial cells of the organism, bile-type epithelial cells exhibit a specific expression profile of cytokeratins. Normal biliary epithelium co-expresses CK7 and 19. However, these markers are not specific for cholangiocarcinoma, and many others are also supportive in differential diagnosis. To date, in everyday practice, decisions and classifications are largely based on the anatomical site of origin, along with histopathological morphology and immunohistochemistry, as we see in NCCN guidelines. And if we have a resection of, for example, intrahepatic cholangiocarcinoma, some parameters should be reported for cancer with cholangiocyte differentiation, such as carcinoma in situ or high-grade dysplasia, number and size of tumors, number of regional lymph nodes evaluated and infiltrated by malignancy, metastatic disease, histological differentiation, vascular invasion, perineural invasion, resection margins, cancer perforation of visceral peritoneum, or direct invasion into adjacent extrahepatic structures. It is important to evaluate the non-tumorous liver parenchyma as well, which means that it is preferable to indicate the presence or absence of chronic liver disease and report the degree of fibrosis and the presence or absence of cirrhosis. For extrahepatic cholangiocarcinoma, reported parameters are a little bit different. Like, for example, we have to report tumor extent, depth of invasion into or through bile duct muscle layer or fibrous tissue, bile duct wall surrounding adipose tissue, adjacent hepatic parenchyma, main portal vein, etc. This outlines the importance of strict macroscopic evaluation. Today, molecular analysis has become one of the most important components of tumor evaluation. An increased understanding of the biology of cholangiocarcinoma based on next-generation sequencing of tumor tissue has identified molecular subgroups harboring actionable mutation with the accelerating emergence of novel treatment operations, such as FGFR2 fusion and TRAC fusion and IDH1 inhibitors, for example, with many others under evaluation. For 2025 NCCN guidelines, Recommend molecular testing for unresectable or metastatic biliary tract cancers, which include microsatellite instability testing, tumor mutational burden, hair overexpression and or amplification, red gene fusion, KRAS G12C mutation, etc. These tumor tissue biomarkers embody not only diagnostic value, but might also may aid to predict prognosis, overall survival, and or tumor recurrence, or even guide therapeutic decisions and assess responses to potential adjuvant therapies. Although a high genomic heterogeneity of evidence of cholangiocarcinoma tumors, specific genetic alterations were reported according to the cancer subtype. For instance, while small bile duct intrahepatic cholangiocarcinomas usually present mutation in IDH1, 2, and FGFR2 fusions, large duct intrahepatic cholangiocarcinomas, perihilar cholangiocarcinomas, and distal ones more constantly display QRS and or TP53 mutations. Furthermore, transcriptomic analysis of intrahepatic cholangiocarcinoma tumors allowed the identification of two distinct subtypes, the inflammation subtype, mainly enriched in inflammatory-related genes, and the proliferation subtype, which was characterized by the increased expression of oncogenes and related with worse prognosis, pinpointing the relevance of tissue biomarkers in predicting prognosis. At the same time, multi-omics-based characterization provides a better understanding of intrahepatic cholangiocarcinoma's heterogeneity. Furthermore, the molecular subtypes in intrahepatic cholangiocarcinomas can apply to novel therapeutic opportunities, drug development for multi-omics-driven biomarkers, and potentially effective therapeutic strategies. All this is good if there is a sufficient amount of tumor tissue, which is not always the case. If tissue is too scant or not available, it is considered to repeat the biopsy depending on the tumor accessibility and clinical context. However, sample collection for histological confirmation is sometimes complicated and not recommended in specific circumstances, such as when considering transplantation for patients with peripheral cholangiocarcinoma due to tumor location and the increased risk of peritoneal seeding. So, the implementation of liquid biopsy techniques is necessary for non-invasive predictive biomarker testing and treatment optimization in patients who lack a suitable tumor specimen, have failed previous molecular analysis, or are clinically ineligible for rebiopsy procedures. The emergence of blood-based non-invasive circulating next-generation biomarkers such as circulating nucleic acid, circulating tumor DNA, cell-free non-coding RNA, cytokines, proteins, metabolites, extracellular vesicles, circulating tumor cells, etc., is providing numerous platforms for investigation. When integrated together with the help of digital tools, all methods of pathological examination create a truly multimodal diagnostic approach in which each layer adds a new dimension to understanding the tumor. This integrated model allows pathology to move beyond a purely descriptive role. It enables us not only to define the tumor type, but to characterize its biological behavior, predict its clinical course, and identify its specific vulnerabilities. Most importantly, it allows us to determine which targeted therapy is most appropriate for each individual patient. In this way, pathology becomes the central link between tissue and treatment, transforming diagnosis into a strategic tool for personalized medicine and ensuring that every patient receives the most precise, predictive, and effective care possible. Thank you for your attention.
Hello, everyone. Welcome to OncoDaily Summit 2026. Today, we are going to discuss the gallbladder and bile duct cancers, as this month is the Gallbladder Cancer Awareness Month. We are very delighted to have you join us for this focused discussion on one of the most challenging and evolving areas in gastrointestinal oncology. And I'm very pleased to welcome our first speaker, Dr. Nikhil Agrawal, lead gastrointestinal hepatobiliary surgical oncologist at Apollo Hospitals in Delhi and Gurugram, India. Dr. Nikhil Agrawal, thank you so much for joining us. The stage is yours.
Thank you, Sajay. Thank you very much for giving me this opportunity, and I'm happy to share my learning and experience with esteemed audience because gallbladder and biliary tract cancers, uh, unfortunately, the treating modalities are not very effective, and surgery, if possible, is the only means of cure in these patients. Uh, Obviously, surgery is always associated with some amount of morbidity and risk. And in an effort to decrease that risk, we keep evolving, keep adding modalities which will decrease the morbidity of surgery. And tool, which is robotic surgery. We used to do minimally invasive surgery earlier, which was like laparoscopic surgery. But laparoscopic surgery had certain disadvantages, and some of those disadvantages has been taken care of with robotic surgery. I'll just briefly overview the current role of robotic surgery in gallbladder and biliary tract cancers. Um, can you see my screen? Yes. Sergey, can you see my screen? Can I continue?
Of course, we can see the screen and you can continue your presentation.
Sure. Okay. Thank you. So, when we talk about gallbladder and biliary tract cancers, we are talking about. It's not moving. Okay. See, I cannot see your screen. So, is it moving now?
It is on the second page of the presentation, I guess, biliary tract cancers, anatomic classifications.
No, this is not my screen.
Can you see the screen? Because I think everything is all right, and you can.
So, this
Yes.
is your screen. This is not my screen.
And which page do you need?
I need the second page of mine, which is bladder and BTC disease burden.
Okay.
I'm
Can you see
projecting
it
that.
now? BTC disease burden.
Yes. Yes. I
Okay.
can see it now.
Mhm. So if everything is good, if everything is all right, you
Yes. Now,
can. Yeah, you can continue.
so
Thank you so
when we
much.
talk about biliary tract cancers, uh, we talk about cancers, perihilar cholangiocarcinoma, intrahepatic cholangiocarcinoma, and cholangiocarcinoma. In our part of the world, uh, gallbladder cancer is quite common. So this is the most common biliary tract cancer we see, but probably the Western audience sees more of molar cholangiocarcinoma and distal cholangiocarcinoma. And most of these diseases are mostly asymptomatic in the early stages. So, unfortunately, by the time we detect them, they are already advanced. Only a proportion of these patients will actually undergo surgery. And when feasible, this is the only chance for long term survival and cure. Here, I would want to also add that now systemic therapy of advanced biliary tract and gallbladder cancer has evolved. The landscape has completely changed, and we have much more modality than the standard chemotherapies which we used to have. We have immunotherapy, we have targeted treatment, and now we have molecular markers which our medical oncologists talk about, and that has changed the landscape of treatment of disease. But when it comes to uh, surgery, the standard be resections. Now, the problem with open HPB resections, open resections in these gallbladder and biliary tract cancer was that these are large incisions. There's significant blood loss and operative morbidity as well as mortality is on the higher side. Now, when we talk about surgery for gallbladder cancer, then we have to do a radical cholecystectomy. For hilar cholangiocarcinoma, it's extended right or left hepatectomy, sometimes with vascular resection and reconstruction. And these are the surgeries which are, associated with a morbidity, that is complication rate of almost to the tune of 30-40%. They are also associated with mortality. That will depend on the extent of surgery, but they also range from 2, 3, 4, 5%. Once you have done this surgery, the hospital stays are longer and there is delayed recovery. So these patients, quickly do not go on to receive adjuvant treatment, which is known to improve survival. And sometimes they don't receive adjuvant therapy at all. So, in an attempt to circumvent this problem of open HPB resections, which is associated with the problems we just enumerate, and make it more acceptable to the patients, since moved on to doing minimally invasive surgery. So, minimally invasive surgery include both laparoscopic and robotic surgery. There are some challenges of laparoscopic surgery. What happens in laparoscopic surgery is that the vision is good, but the movements are very fixed. So the laparoscopic instrument has only arm fixed instrument which moves only like this. They don't move like our wrist moves, and it's very challenging for the patient. Say for an example, if you do a 10-hour laparoscopic surgery, what we used to say that the laparoscopy has transferred patient pains to the surgeon's shoulder. So that's the problem with laparoscopic surgery. And definitely, the blood loss is also reduced, pain is reduced, hospital stay is reduced when compared to open surgery in laparoscopy as well as. But the advantages of robotic surgery, specifically for HPB, is that we get better vision. So, robotic camera is much better camera. There is a 3D vision, there is a console in which you can see, and it almost looks like you're very close and very, get a magnified view. The robotic arm is almost like your arm, so it has 360-degree of movement, and plus it gives you a stability, so it filters out all the tremors or unintended movements, and then you can very finely do the dissection. And with the combination of these two factors, we can very well do these complex surgical procedures with minimally invasive technique. Now, when we talk about application of these techniques to biliary tract cancer, so we'll talk about gallbladder cancer, we'll talk about intrahepatic cholangiocarcinoma, we'll talk about perihilar cholangiocarcinoma, and we'll talk about distal cholangiocarcinoma. When it comes to gallbladder cancer has marked regional variation. It has high incidence in our country, especially in our belt. I stay in Delhi. This is North India, and this is where you see a lot of gallbladder cancers. So is the case in Chile. And it is also detected, when somebody undergoes surgery for gallbladder cancer, benign gallbladder disease, that is gallstone disease, and almost 1 to 2% of these patients will be detected to have a cancer. Now, whenever you have either a suspected gallbladder cancer or a gallbladder cancer or an incidental gallbladder cancer, where the stage is more than T1B, we have to do a radical cholecystectomy. Now, when we talk about the principles of radical cholecystectomy, we have to do a cholecystectomy with hepatic wedge. In the cases of incidental gallbladder cancer, we don't have to do a en bloc cholecystectomy. It's only a hepatic wedge. And if it's large gallbladder cancer, it's not a small one, then sometimes we have to do a formal hepatectomy. And then we have to do a systemic lymphadenectomy along the hepatoduodenal ligament. When we are talking about lymphadenectomy along the hepatoduodenal ligament, we have to remove lymph nodes along the left of celiac axis, hepatic artery, and left of hepatoduodenal ligament, and all around the hepatoduodenal ligament. That's called station 8, station 12. And then we have to remove the lymph nodes along the posterior aspect of pancreas, which is called as station 13, or posterior superior pancreaticoduodenal lymph node. We will also generally send frozen of the cystic duct margin. If it is positive, then we might have to resect the extrahepatic bile duct. So basically, we have to do a complete R0 resection with complete and adequate nodal clearance, right? And when we talk about this radical cholecystectomy or completion radical cholecystectomy, especially a robotic approach, then definitely we will not want to take advanced cases where it's a T4 disease, some extra organs are involved, or vascular invasion is there. We would want slightly earlier tumor. So it should be a T1B, T2 gallbladder cancers, maybe very early T3 lesions, selected T3 lesions. There should not be bulky lymph node. There shouldn't be any vascular invasion, and incidental gallbladder cancers are particularly suited for this robotic radical cholecystectomy. Well, the patient selection has to be good, because if you don't take such kind of patients, then the results are not likely to be great. When we talk about the operative setup, we can do it in a supine position, or we can do it in a split leg position. The advantage of a split leg position is that the assistant, who the bedside assistant who's sitting there, it's more comfortable for him because he gets direct straight line access to the operative field. If you do it in a supine position, then that fellow is sitting on the left side and he finds it a little difficult. The patient is in reverse tenderness position, which is slightly head up and slightly right up. And generally we put a straight line slightly just above the umbilicus, and we shift the whole system slightly towards the right. And if you're using a Da Vinci X, then the docking is from the patient's head side, and if you are using a XI, then it generally comes from the right side. Now I'll show you a brief video of robotic completion radical cholecystectomy, the operative steps. Here you can see this is a video where I have kind of make it run a little faster so that you can, in the interest of time. And here you can see we are at the hepatoduodenal ligament, right? So you can see the bile duct here. If you can see my cursor, yes, you can see my arrow. So you can see this is the bile duct. Now we are going in the hepatoduodenal ligament, center of it. So this is the artery. Now I'm dissecting on left hepatic artery. This is one branch, and you will also see the right branch here. So all fibrofatty and nodal tissue from the center of hepatoduodenal between hepatic artery and bile duct on both sides, and liver on top and duodenum at the bottom, we will clear, right? So this is a systematic approach which I have named prune, peel, and posterior approach. Prune is like you take off the cap. So this was the part we just removed. Then peel is what we will do. We'll peel the lymph nodes from left side of HDL, from top of hepatic artery and left of celiac axis. We'll not remove them. We'll just drop them, right? That's called as peel. So now what I'm working on is on station 8 lymph node that is above the hepatic artery. And then you can see the hepatic artery. You can see there was a lymph node along the GDA. You saw this hepatic artery has now been cleared, not completely, but we have dropped the tissue from there. This is left side of portal vein. This is portal vein. So if you see the stability, we can, dissect very close to these blood vessels. This is the celiac axis here. This is the celiac axis. One of my arm is now retracting the liver, and now I'm just drop them. Now what I'm doing here is cockerization. I am lifting the duodenum of the retroperitoneum IVC completely. This step is required to remove the retropancreatic node and take the same dissection plane to the SMA and celiac axis. I call it the posterior part of prune, peel, and posterior approach. Now I'm starting the station 13 lymph node dissection. So I'm going behind the pancreas. All the nodal tissue is removed. And now the same plane from behind the pancreas, behind the pancreas, and in between the nodal tissue and the pancreas, will go superiorly to the behind the portal vein, behind the bile duct, and medially it will go up to the celiac axis and SMA. Right. I'm just checking it there. We will loop the bile duct here. You can see we have completely removed all the lymph nodes from hepatoduodenal ligament. These are station 12 lymph nodes. Freeze the portal vein. Now we'll go behind the portal vein. This is the area where the portal vein is going into pancreas, and this is the junction of nodes from posterior superior pancreatoduodenal nodes to the retroportal and retrohepatic. Now see the lymph node we dropped from anterior to hepatic artery now can be accessed from the right side posteriorly. So you can see we have completely removed all the lymph nodes. So this gives us a very good lymphadenectomy. You just saw the left um, renal vein there, and there's some more tissue on bile duct, which we will remove separately. This is a completion radical cholecystectomy. This is a redo surgery. This patient underwent uh, cholecystectomy, and the biopsy came as T2 gallbladder cancer. And then we are doing a completion surgery. And we will also do a liver wedge resection in this patient. That's more straightforward and simple. The more difficult part is the lymphadenectomy, where the robotics help compared to the laparoscopic. That's what we wanted to demonstrate here. Now, if we look at the result of robotic radical cholecystectomy, there is this review from 2022. I mean, before that, I'll just tell you, in this patient, or in our series, so we have a series of around 10 patients we've done so far, and in that we have a median lymph node of around 14. Fortunately, no major morbidity, no mortality, and the median post-operative hospital stay is around 3 days. So looking at the literature, this is a review from 2022. And in this, there were 7 studies and 74 patients. There were conversion rates were around 5.4%. Post-op complication rate was 6.8% without any mortality. R0 resection rate was to the tune of 97%. Mean in this series was 9. For us, it was 14. And 2-year survival is 60 to 100%. And in this, they figured out that precision dissection, visualization, dexterity was better with the robotic approach, and blood loss was reduced, hospital stay was shorter, and morbidity was lesser when compared to the open radical cholecystectomy. Obviously, this is a small series. I mean, everybody is currently having a small series of robotic radical cholecystectomy. Cost and accessibilities are issue. Patient selection is an issue. But beyond these things, it's definitely feasible, definitely doable, and helps patient. When we look at a larger robotic series of all biliary tract cancer, out of that, if we look at the robotic gallbladder cancer cohort, there were 113 patients from a review in 2022, and the tumor was medium T1B to T3, and operative time mean was 277 minutes with a mean blood loss of 260 ml. Conversion, morbidity, and R0 resection rates and lymph node yield was almost same as I enumerated in the previous study. And if we use open radical cholecystectomy as the benchmark, the outcomes were comparable except the hospital stay and recovery time, which was lesser. So now, once we are done with the gallbladder cancer, other biliary tract cancers include, distal cholangiocarcinoma, hilar cholangiocarcinoma, and intrahepatic cholangiocarcinoma. Intrahepatic cholangiocarcinoma are very rare and they generally require a hepatectomy. So, apart from they being a biliary tract cancer, when it comes to surgery, they are almost like a liver resection, and that's a separate discussion. So, I think for the sake of discussion, we can talk about here distal cholangiocarcinoma and hilar cholangiocarcinoma, which require a totally different approach. And a distal cholangiocarcinoma is treated with a pancreaticoduodenectomy or a Whipple procedure. We know this procedure for pancreatic ductal adenocarcinoma, and the goals of surgery are same with a negative margin, nodal clearance. And if we talk about minimally invasive surgery for distal cholangiocarcinoma or a Whipple procedure, the advantages of robotics are the same as we discussed for gallbladder cancer compared to laparoscopic. And this is again a short video of a robotic Whipple procedure. We start the dissection. We are taking off the omentum. We'll reach the pancreas, and then we will demonstrate the gastroepiploic vein. We will take the gastroepiploic vein at its insertion into the portal vein. This is the gastroepiploic vein. This is clipped and divided. We retract the liver. This is the hepatoduodenal dissection as we demonstrated in gallbladder cancer. Here we'll remove the lymph nodes along the hepatic artery, and then the aim is to demonstrate the gastroduodenal artery. This is right hepatic artery, which we have to clip and divide, and then this is the gastroduodenal artery. So the clipping and division of gastroduodenal artery is a very important step in the Whipple procedure. And we are looping that. We can see the portal vein here. Then we will do the cholecystectomy. On the lesser sac side and the greater sac curvature is divided, and then we divide the stomach with a stapler. Now the neck of the pancreas is being divided. We will encounter the pancreatic duct here. These are branches of the portal vein going into the pancreas, which is being divided. And then the jejunum is brought to the right side. And then after that, once the jejunum is brought to the right side, the pancreatic head is dissected completely off the SMA. Right? And then we have to divide the bile duct. So that completes the resection part of the procedure. Now we have to reconstruct it. So pancreatic duodenectomy requires a reconstruction of the whole gastrointestinal system. So we have to attach the jejunum to the pancreas, to the bile duct, and to the stomach. So this is the pancreatico-jejunal anastomosis. The posterior layer has been completed. This is the pancreatic duct, and this will create an opening in the jejunum. We're just checking with infant feeding tube. This is pancreatic duct being anastomosed to the jejunum. This is called as duct to mucosa. And once we have completed that, then we will take the anterior layer of pancreatico-jejunal anastomosis. Let's just fast forward this a bit. We've completed this, and then we'll complete the anterior layer. Then we have to anastomose the jejunum to the bile duct. This anastomosis is completed, and then we have to anastomose the jejunum to the stomach. So if we look at the cohort study of robotic pancreaticoduodenectomy versus open pancreaticoduodenectomy, in that 375, this is a Dutch national cohort from 2016 to 23, and 375 patients underwent a robotic assisted pancreaticoduodenectomy compared to the 1300 open pancreaticoduodenectomy. And these were patients who had tumors which were not having any vascular involvement. So when compared, the robotic cohort had similar major complication and mortality rates, and intraoperative blood loss was reduced. Length of stay was comparable, and OS was also same, and 5-year survival, R0 rates, and lymph node yields were similar. So this study demonstrated that robotic pancreaticoduodenectomy is almost similar to the open pancreaticoduodenectomy. Now let's come to the hilar cholangiocarcinoma. Hilar cholangiocarcinoma is again, as I said, a very challenging surgery where we have to remove the part of the liver, mostly a right or a left, mostly an extended hepatectomy. and morbidity and mortality rates are on the higher side, and R0 resection rates are typically around 75%. When it comes to robotic perihilar cholangiocarcinoma resection, we should choose patients which are not very advanced, whether there is no vascular involvement, and they are, bismuth 1, 2, 3, without bilateral involvement. With adequate future liver remnant, we have to do biliary drainage before that. Patient's nutritional status has to be optimized, and it has to be done in, expert centers. Again, looking at the review done in 2022, 146 patients with perihilar cholangiocarcinoma, operative time was 401 minutes, blood loss 348 milliliter, and conversion was 7%, morbidity 52, and with a major morbidity only 12%, and a mortality of 1.4% with a hospital stay of 15. And lymph node yield was 4.2. So this data is almost comparable to the open cholangiocarcinoma series. And if we look at a systematic review of robotic hilar cholangiocarcinoma, which included 12 studies, uh, mean operative time was again 6 to 10 hours with a blood loss of 600 ml, minimal conversion, and morbidity, mortality, and R0 resection were comparable to the modern open series. So if I sum up the whole discussion here, we can see that the outcomes are good. And if we look at the meta-analysis, which compared of all the available series, larger available series of robotic and open hilar cholangiocarcinoma surgery, so there are 4 studies, 267 patients, which compared 102 robotic and 165 open resection. There was no significant difference in operative time, transfusion rate, complication rate, length of stay, and R0 resection, lymph node metastasis. Everything was similar, though we don't have long-term survival data. We can conclude that, for earlier detected biliary tract cancers, which are a surgical candidate, which do not have vascular involvement, which are not T4 disease, robotic approach is almost as good as open approach, and it does give in some patients, the benefit of a minimally invasive surgery. So with this, I conclude my talk, and thank you very much for your patient listening.
Thank you so much, Dr. Agrawal, for your insightful details about the robotic-assisted surgery and the approaches you do for the gallbladder cancer and how you manage at your institution and beyond. Thank you so much for your expertise and your time spending with us, sharing your insights. That was very wonderful to hear from your side. Now we are continuing our session, and I'm very delighted to welcome our next guest, Dr. Erman Akkus from Ankara University, who is a medical oncologist and will share his perspective on how he treats gallbladder and bile duct cancer in 2026. Thank you, Dr. Akkus, for joining us, and the floor is yours.
Hello. So I share my slide first. So is it visible, and am I audible for presentation?
Not yet, but if you have shared your screen, then we'll see it in shortly, I guess.
Actually, indeed, I shared, but okay, I'll try again.
Yes.
Have you seen?
Not now. At the moment, it's not visible, but it was a second ago.
Okay.
Yeah.
Now?
Yes. Now,
Okay.
Now it's visible. Now
Okay.
it's good.
Okay. Thank you. So first, thank you so much for your kind invitation, and I'm happy to join this summit in the cholangiocarcinoma awareness month. And I'm Erman from Ankara University Faculty of Medicine, Department of Medical Oncology. So my presentation will be about oncological treatment of biliary tract cancers. So starting with the epidemiology. So as we know that the biliary tract cancers are not common cancer types. So around 0.3 to 6 cases per 100,000 inhabitants in Western countries yearly. And it reflects around 20,000 new BTC cases annually in the USA. And the statistics, epidemiological data comes from GlobalCan, US cancer statistic data. But we have a problem. We had a problem for years for these cancer types because the ICD codings was problematic, and liver cancer, hepatocellular carcinoma, and intrahepatic cholangiocarcinoma was pooled. And so we didn't have a very refined epidemiological data for the biliary tract cancers for years. But according to the NCCN registry in Europe, intrahepatic and extrahepatic cholangiocarcinomas were included and excluding gallbladder cancers. And the 40% of patients presented with localized disease, and 30% at regional disease, and 30% was metastatic at the diagnosis. So when we move to diagnosis and staging of biliary tract cancers, as we know that the biliary tract cancers are divided for subtypes. So intrahepatic cholangiocarcinoma, periolar cholangiocarcinoma, distal cholangiocarcinoma, and gallbladder cancer. So the median age is around 60 to 70, and symptoms is generally jaundice, pain, and weight loss, and sometimes it's asymptomatic and detected incidentally in the imaging. So when we have a suspicion for the biliary tract cancer, and or if we see in the imaging, we perform ultrasonography, CT or MRI, and tumor markers. So after that, there's a need for multidisciplinary planning indeed. So is it resectable is the first question. So can we go to the upfront surgery? If it's not, do we need a tissue diagnosis and biopsy? And do we need an intervention for the biopsy or for the drainage of the cholestasis and to lower the bilirubin levels? So based on the imaging, we stage the disease and TNM staging, tumor node, and metastasis. As a note, we should say that the tissue diagnosis and enough samples may be a problem in biliary tract cancers, especially for periolar cholangiocarcinoma. So for the localized disease, the treatment is surgery. So when we look at these paintings, these figures, it's generally easy to say that it's intrahepatic and gallbladder and extrahepatic periolar. But as we see in the presentation of Dr. Agrawal, so it's a very complex anatomical region, and the surgery is not easy. So always should be done in expert centers. According to the NCCN registry, 50% of patients underwent resection, and R0 resection rates was 35. For example, in the intrahepatic cholangiocarcinoma, 90-day mortality can be around 6%, and major complication rate is around 20%. And even in periolar cholangiocarcinoma, as pointed by Dr. Agrawal, and the mortality can reach the 30%. So quality of surgery and postoperative complications are major determinants of the prognosis and eligibility for the adjuvant chemotherapy. So for the localized disease, after surgery, the adjuvant treatment is the standard adjuvant treatment is the adjuvant capecitabine. And the adjuvant capecitabine data comes from the BILCAP trial. In the BILCAP trial, in the intention-to-treat analysis, there was a numerically higher survival in recurrence-free survival and overall survival, but it wasn't statistically significant. The median OS was around 50 months to 36 months, and the median RFS was 24 months to 17 months. But in the pre-specified per protocol analysis, there was a statistical significance, so the capecitabine becomes the standard adjuvant treatment. So there are some other trials in the adjuvant treatment of biliary tract cancers. The other is from the East, ASCOT trial, S1 versus observation. There was OS benefit, but no RFS benefit. And Prodigy trial investigated GEMOX versus observation, and there was no benefit in the OS or RFS. And in the BCAT trial, gemcitabine versus observation was investigated, and there wasn't any benefit. So we did a pool analysis of these available phase 3 trials, and we see that the 5-FU based adjuvant treatment is beneficial in the adjuvant treatment of biliary tract cancers, but not gemcitabine-based treatment. But the point was that the benefit was prominent in the short term, in the first 2 years. So the adjuvant treatment delay recurrence, but not enough cure benefit is derived from this adjuvant treatment. So we need effective adjuvant treatments with sustained long-term benefits and more curable disease in patients. So patient selection is key in this. So we know that the splitting gemcitabine is effective in the metastatic setting. So the question is whether it is effective in adjuvant setting. So there was a STEM trial from Korea, included not positive extrahepatic cholangiocarcinoma patients and randomized gemcitabine plus splitting versus capecitabine, and did not show any benefit with gemcis in the adjuvant setting compared to capecitabine, and with increased toxicity. So when we look at the BILCAP recurrence-free survival graph, so we see that the capecitabine provided a benefit in adjuvant setting, but 50% of patients recurred or died despite capecitabine in the first 2 years. But on the other hand, in the fifth year, the 30% of patients did not recur despite only observation. So we don't know which patients are actually benefit from the adjuvant treatment. Indeed, the treatment completion rates is around 50-60% in the adjuvant setting. So similarly, in our center, 50% of patients was eligible to adjuvant chemotherapy after surgery, and 40% needed dose reductions, and 30% couldn't complete planned cycles, and grade 3-4 adverse events was around 30%. So this patient population is a vulnerable group, so it's very important to balance between the efficacy and toxicity, and which patients are likely or not likely to benefit from even surgery and adjuvant treatment is not known yet. So we use size, lymph node, R10, R0 resection, and R1 resection, and other parameters, but definitely we need a risk scoring or molecular features and liquid biopsy or ctDNA in features. But currently, capecitabine is recommended for all resected biliary tract cancer patients. On the other hand, we don't have a real-world data. There's just one from French data that's showing results in line with BILCAP trial. So we designed a national real-world data study and included patients who had resection and underwent adjuvant chemotherapy. 44 centers and 513 patients were included and distributed to all our country. So the results are under preparation and will be submitted to for the publication soon. So what about radiotherapy in the adjuvant setting? Indeed, we don't have a randomized control trial for the radiotherapy. The SWOG trial showed that this is a single-arm study in extrahepatic and gallbladder BTC, and they show that the radiotherapy concurrent with capecitabine and GEMCAP is feasible. And the large real-world data from US database registry data showed that adjuvant chemotherapy or chemoradiotherapy is beneficial compared to surgery alone. But we don't know whether adding radiotherapy to chemotherapy is beneficial or not. So we don't have data for this yet. But when taken together, all these data, the neoadjuvant and perioperative approaches are becoming more popular in the resectable stage of biliary tract cancers. And recently we have seen some trials showing neoadjuvant chemotherapy and chemoradiotherapy may be feasible and beneficial in this patient group. So in the future, we will see a paradigm shift to the perioperative treatment in the resectable biliary tract cancers. On the other hand, we don't have good data, randomized data for the local regional therapies in biliary tract cancers. So in future, we use these local regional therapies in practice, but more evidence-based data is needed for the future treatment. So when we move to the advanced and metastatic disease, the standard regimen was cisplatin gemcitabine for years, based on the ABC trial, which investigated cisplatin gemcitabine versus gemcitabine and showed the median overall survival is around only 1 year. But after these long years, we have seen new developments in the metastatic treatment of biliary tract cancers. First, the TOPAZ trial investigated adding durvalumab to cisplatin gemcitabine, and Keynote trial investigated adding pembrolizumab to cisplatin gemcitabine. Both trials showed significantly improved overall survival and around 13 months, and there wasn't any deterioration in the quality of life in these studies. So these two regimens become the standard recommendation for the first-line treatment. As a note, the PD-L1 expression was not a biomarker for the treatment selection in these trials. So based on ESMO guideline and the other guidelines, as I said, the first-line treatment is now cisplatin gemcitabine plus immunotherapy. And in the second-line treatment, so the ABC trial investigated FOLFOX plus symptom control versus symptom control, and it showed significant overall survival advantages around 6 months. And recently we have seen the pooled results of NIFTY and NALIRIC trials, and NALIRIC plus 5 in the second line, although the statistical significance was borderline, but there was a numeric improvement. So these both chemotherapy regimens are recommended for all comers in the second line treatment. But one problem with the biliary tract cancer patient is that the only a small portion of patients is eligible to chemotherapy in the second line. So in our center, for example, only 36% of patients who received first-line treatment was eligible to second-line treatment because of the complications or performance score, or because of the due to the disease progression. But there's a hope in the treatment of biliary tract cancers, and up to 50% of these cancers may have potential actionable genetic alterations indeed. For example, in the intrahepatic cholangiocarcinoma, IDH mutations and FGFR2 fusions and HER2 amplification and overexpression. So in the last few years, we have seen a significant improvement in the treatment of in precision treatment of biliary tract cancers. And first, the IDH1 mutations is observed around 20% of intrahepatic cholangiocarcinoma, and CLAR-HD treatment ivosidenib versus placebo was investigated, and median overall survival was around 10 months with ivosidenib, and median PFS was also significantly improved. And FGFR2 fusions is around 20% of intrahepatic cholangiocarcinoma. In FIGHT trial, pemigatinib, and Phoenix trial, futibatinib was investigated, and dramatically high median overall survivals were observed around 17 and 20 months at the second-line treatment of biliary tract cancers, and response rates was also very high, around 30 and 40%. And other FGFR inhibitors that investigated in biliary tract cancers are erdafitinib, lirafugratinib, and infigratinib. And recently we have seen the results of tinangotinib, and even it was effective in FGFR2 pretreated patients, inhibitor pretreated patients. So, but the oldest drug is here, the pemigatinib, and we did a meta-analysis pulling the available data of pemigatinib based on the Precision BTC network study, and it included 8 studies and totally 327 patients, and the female gender was predominant, and 60% of patients had received pemigatinib in the second line, and the remaining received in third line and beyond. And the response rate, the pooled response rate was 40%, and disease control rate was around 80%, and showing the efficacy of pemigatinib in FGFR fusion biliary tract cancers. And another target is BRAF mutation. It's observed around 3% of BTCs. In the ROAR study, dabrafenib, trametinib showed a median OS of 14 months and median PFS of 9 months. Response rate was 50%. And HER2 overexpression and amplification is mainly observed in the extrahepatic cholangiocarcinoma and gallbladder cancer instead of intrahepatic cholangiocarcinoma. And Destiny Pan tumor study showed trastuzumab deruxtecan provided a median OS of 12 months and median PFS of 7 months. And in Horizon BTC study, zanidatamab has been shown to be effective and in terms of progression-free survival and response rate. So, and other treatments that investigated in HER2 amplified BTCs is tucatinib, trastuzumab, pertuzumab, trastuzumab, FOLFOX, and neratinib. So, this HER2 is a target in biliary tract cancers. And MSII, although rare, 4% of patients had deficient MMR in biliary tract cancers. In Keynote trial, as a tumor agnostic treatment, pembrolizumab has shown a median OS of 24 months in BTC, and dostarlimab is another option for the tumor agnostic treatment. So, but there are other rare targets and therapies for BTCs and NTRK fusions, RET fusions, and BRCA and KRAS, G12C mutations, and TMB can be targeted by available drugs. And there are emerging therapies in BTCs. Claudin, for example, in positive in 15% of gallbladder cancer, and MDM2 amplification is observed. And there are ongoing trials for these novel targets and therapies. So all these targeted agents are investigated in second line and beyond in biliary tract cancers. So after first line immunotherapy plus chemotherapy, in the second line for all comers, the chemotherapy is recommended. But if there is a alteration and if the drug is available, the targeted treatment is the option in the second line. But molecular analysis open new horizons in the biliary tract cancers. It's for example, in resected biliary tract cancers, it's possible to detect recurrence by circulating tumor DNA. And it's also possible to diagnose biliary tract cancers from exfoliated tumor cells and circulating tumor cells, and from blood and from the biliary sample. And it's also it's important to emphasize that the concordance between ctDNA and tissue genomic profiling is high, around 84%. So we can use ctDNA to test target mutations, and it's also possible to follow acute resistant mutations by ctDNA when we treat with FGFR inhibitors. So on the other hand, and 5% of BTCs has mutations in hereditary cancer variants and homolog recombination deficiencies. So it has been shown as in ovarian cancer, the tumors that has this deficiency has a sensitivity to platinum-based chemotherapy. So this can be a biomarker for even chemotherapy. But although the treatment portfolio and the precision medicine has evolved in biliary tract cancers, so the accessibility and availability is a problem. So in the European survey, the significant portion of centers or physicians do not have access to NGS easily, and these targeted treatments are not available in most of the centers in most of the countries. Pemigatinib is generally accessible, but the other drugs are either not available or not reimbursed in the countries. So finally, we know that the young onset, early onset gastrointestinal cancers are increasing around the world and is a major problem. So it's also important for the biliary tract cancers because these BTCs has worse and bad prognosis and early onset, which defined as a diagnosis before 50 years old. Has a loss of survival at young age. So this group is has a unique features such as more intrahepatic location and more FGFR2 fusion. So we, for this patient group, it's important to access the NGS and targeted treatments indeed. So we should do more for these young patients. So my final messages is that the diagnosis and surgery might be challenging in biliary tract cancers, and adjuvant treatment is capecitabine monotherapy currently, but needs to be improved. And in the first-line treatment of advanced disease, statin gemcitabine plus immunotherapy, and we should do molecular profiling at diagnosis. In the second line, if there's a mutation in the targets and the drug is available, then targeted treatments are the option, and FOLFOX or Nolary-5 chemotherapies for all comers. And local therapies, radiotherapy, neoadjuvant approach, transplantation is used in clinical practice, but we need more data and trials for that. And personalized precision treatment is promising in biliary tract cancers. And liquid biopsy and ctDNA seem to be most promising candidate tools in practice for near future. So thank you so much for your attention. I'm happy to join this summit, and I'm ready to listen any comments and questions to answer the questions. Thank you so much.
Thank you so much, Dr. Akkus, for your practical messages and sharing your expertise. It was very lovely to have you, and thank you for sharing your time with us.
Okay, thanks so much.
And now we will move forward to hear the perspective on contemporary treatment types of biliary tract cancer from Dr. Thatcher.
Good day, everyone, and thank you to the OncoDaily team for having me on. My name is Thatcher Human. I am a GI medical oncologist from Vanderbilt University in Nashville, Tennessee, USA. And today I'm going to be talking about my approach to and strategies of using systemic therapy in the biliary tract cancer patients that I treat in the clinic. So here are my disclosures. And just in terms of the focus for this talk, I'm mainly going to be reviewing the standard treatment paradigms for biliary tract cancer with a focus on the advanced disease setting, and also will be highlighting the more common actionable molecular features of biliary tract cancer and currently approved and exciting therapies that are hopefully on track to be approved soon. So just an introduction to biliary tract cancers. This is somewhat of an umbrella diagnosis that encompasses cancers of the bile duct or cholangiocarcinoma, and that includes intrahepatic cholangiocarcinoma, extrahepatic cholangiocarcinoma, which can be further subdivided into the perihilar subtype of cholangiocarcinoma, and also the distal extrahepatic cholangiocarcinoma. And finally, gallbladder cancer, also grouped with that diagnosis. Overall, these are rare cancers in the US, but they have a growing incidence. Risk factors include primary sclerosing cholangitis, cirrhosis, liver flukes, metabolic syndrome. In the US, we see about 15,000 new cases diagnosed annually, and the overall survival at 5 years is just on average 15 to 20%. When diagnosed, a little less than a third of these patients are resectable. And even when resected, I'm just listing out those 5-year overall survival rates and also the recurrence rates following that curative intent surgery, where we see that these still tend to be coming back, even despite best curative efforts, and that risk of recurrence gets much higher when we're seeing positive margins, positive lymph nodes. In the cases of both, it's more than 90% chance of the cancer returning, and even without those features, we're still looking about half of those, potentially a little bit more, still returning after surgery. And in that unresected population, the prognosis is grim, even if these are early stage unresectable patients, locally advanced and metastatic. We're really not seeing those folks get to 10% 5-year overall survival rates. And the clinical reality of treating patients with biliary tract cancer is we're not often able to get to multiple lines of therapy. I would say this review or patient experience study is accurate to the patients that I'm also seeing in clinic, where I would say only a little bit more than half are making it to second line, and 1 in 5 are making it to third line therapy. And so these patients can be quite sick when you first meet them, and if that's not the case, things can turn very quickly at time of progression. So really, all the more reason that we have to be maximizing benefit from the earlier lines of therapy and getting things like molecular sequencing done early on to identify potentially significantly prognosis changing actionable mutation. Okay. But that doesn't mean that progress has not been made. It's been a little bit slower in the all-comer setting. I think the greatest leaps forward and impact have really been made when it comes to the actionable molecular groups within biliary tract cancer, particularly patients with FGFR2 fusions, HER2 amplifications, and IDH1 mutations. So now let's get into approaches to and standards for first-line treatment of advanced biliary tract cancers. I'm going to start at 2010, where we had the ABC02 study, which showed that the combination of the chemotherapy doublet of cisplatin with gemcitabine improved overall survival compared to gemcitabine monotherapy. And this really stayed and still continues to be the mainstay of first-line therapy, and it wasn't without efforts to dethrone it, where putting it up against FOLFIRINOX, adding Abraxane, adding SBRT, adding reformulated or subbing out reformulated gemcitabine. None of these improved upon standard gemcis doublet for first-line biliary tract cancer. Do want to make one note of the addition of S1, which is not approved for use in the U.S. Was the one exception in this slide where that did show a additional survival benefit of adding that chemotherapy on top of the GemCis base. But in general, not much movement on first-line therapy until we've gotten into about 2022, 2023 with the additions of PD-1 and PD-L1 blockade. So the two pivotal studies in the first line setting that led to a change in standard of care, really an addition to standard of care, were TOPAZ-1 and KEYNOTE-966. TOPAZ-1 with the addition of durvalumab, PD-L1 antagonist, and with KEYNOTE-966, the addition of pembrolizumab, PD-1 antagonist. So TOPAZ-1 and KEYNOTE-966 had a lot of things in common. This slide is just highlighting some of the minor differences between the two studies. I think from a design standpoint, what is the main thing that stands out is in TOPAZ-1, after the induction period, up to 8 cycles of the chemo doublet and the immunotherapy, both chemos were dropped. And in the maintenance setting, it was the immunotherapy alone versus placebo. There was some criticism or speculation, I should say, when the data came out regarding this, since sometimes chemotherapy would be continued in that maintenance setting. So KEYNOTE-966 structured it in a way where investigators or primary providers managing patients on that study were allowed to, or had the option to continue chemotherapy in that maintenance setting in addition to the pembrolizumab or placebo. Some differences in the patient populations, and in terms of secondary outcomes, TOPAZ-1 showed a progression-free survival benefit, while that was not shown in KEYNOTE-966. Both showed overall survival benefits. And that overall survival benefit primary outcome, the Kaplan-Meier curves are included on this slide. And what you see is a similar result in that you're getting a median OS of a little bit over a year with the triplet or chemoimmunotherapy, the difference of about a little less than 2 months in terms of absolute difference in median overall survival. And I think what is encouraging from the KEYNOTE-966 data is that the benefit is still sustained even with the option of continuing chemotherapy in that maintenance setting. So really kind of two confirmatory studies that there is a role and a meaningful clinical benefit to the addition of immunotherapy to first-line GemCis doublet chemo. And this slide summarizes some of the key secondary efficacy outcomes of PFS and objective response rates, of which both seeing median PFS of between around 7 months with the chemoimmunotherapy arms, and response rates in the upper 20%, close to 30%. So generally speaking, I'm offering GemCis with either durvalumab or pembrolizumab to all first-line advanced stage unresectable biliary tract cancer patients who I see, unless there's a clear contraindication to immunotherapy. Now, I think there's other considerations that need to be taken into account with these patients. For your more patients that are a little bit more frail, borderline performance status, also thinking about those considerations when a patient has primary sclerosing cholangitis associated biliary tract cancer, and also those with baseline chronic kidney disease. So when when it comes to the more borderline performance status patients, we have data from tourmaline, which I'll get into more details on the next slide, where GemCis durva is feasible and safe in ECOG2 or WHO 2 functional status patients. And we have multiple retrospective cohorts that also look at a every other week dosing of GemCis, and in those series, there doesn't appear to be any compromised clinical efficacy either. And so I think if day 1, day 8 is too intense for those folks, moving to a day 115 Q28 day cycle is a reasonable pivot to make that chemoimmunotherapy more tolerable. When it comes to PSC, we have recent data that shows that these patients are able to tolerate the immunotherapy portion of it, and with a similar immune adverse event rate that is comparable to what was seen in Topaz, where it's really only about a little more than 10% immune-related adverse event incidence. So I wouldn't see that as necessarily a strict contraindication to being able to add the immunotherapy. And then when it comes to CKD and concerns about cisplatin, just remember that we're giving cisplatin at a lower dose. It's 50 mg per meter squared per cycle. So generally, I have a lower threshold on their creatinine clearance, where anyone at 45 or above, as long as they're not on any other nephrotoxic agents and good performance status, I typically am not changing their standard dosing. For those that are more of that CKD stage 3B, closer to creatinine clearances of 30, I think it's very reasonable to be switching out the cisplatin portion for either carboplatin or oxaliplatin. And now we have data from the phase 3B that shows that GemCarbo or GemoxyAlpine, you can also be safely and feasibly giving durvalumab as well. The recent phase 3B tourmaline study was looking at establishing the safety and preliminary efficacy of adding durvalumab to other gem-based combinations like GemCarbo, GemoxyAlpine, and also gemcitabiraxane, as well as looking at GemCis plus durva in performance status ECOG2 patients. And what the most recent presented data at ESMO GI 2025 was showing is that the addition of durvalumab had reasonable response and safety signals in combination with other gem-based chemotherapy regimens. GemCis durva was feasible for performance status 2 patients, and although that these weren't necessarily being powered to compare to each other, the primary outcome was for safety. It is notable here, some of the early objective response data is showing that it would probably be wiser, as long as it is possible and not too risky for the patient, to try to push for the chemo doublet as your base, as opposed to just gem monotherapy alone in combination with durvalumab. So that's first line all-comer biliary tract cancer, systemic therapy for the advanced setting. Now let's talk about second line for all comers. The current standard of care is second line FOLFOX And this is based on the phase 3 ABC06 study, where it was put up against best supportive care. And it did show that second line FOLFOX no bolus did improve overall survival, with the largest separation of the curve being around that 12-month mark, with a 12-month survival rate in the treatment arm of 26% versus closer to 12% in the best supportive care. But as you can see, after we get past 12 months, those curves close very quickly. When it comes to options outside of FOLFOX, the pool is pretty limited at this point. If there's not an actionable mutation or not a clinical trial available, we do have data that's a little bit mixed for biliary, with a PFS and OS benefit demonstrated in NIFTY that was not carried over into a very similar study, biliary. So it remains a little bit unclear just how much of a benefit there is to this regimen. I think, practically speaking, if a patient is still good performance status looking to try, I think it's a reasonable option as long as patient expectations are appropriately managed. So really overall, for second-line therapy, conventional options, no targetable mutation are already through or progress through your appropriate targeted inhibitors. The pool is pretty shallow, and the benefit is unfortunately quite modest. And we're really just limited to our tried and true GI 5FU doublets in this case, that are maybe providing a couple months, and that's if they're working benefit. But that is why it has become so important, not only to be supporting clinical trials in the later line setting, but to be getting molecular analysis, NGS, IHC, on these cancer patients to see if we can come across a promising actionable mutation for them, because that is where we are seeing not just a couple months increase in survival, but potentially something on the order of years. And this is certainly not an exhaustive list of all the notable and important mutations in biliary tract cancer, but with highlighting really the main ones where we're dealing with a high enough incidence of them and enough approved agents where these are probably the ones that we're encountering the most that are management changing in the clinic. So, with intrahepatic cholangio specifically, there's going to be a much higher prevalence of the FGFR2 fusions, IDH1 mutations. When we're getting more into the extrahepatic cholangio subtype, and particularly with gallbladder cancer, the predominant actionable molecular feature for those is going to be HER2 overexpression. And just one thing to note for these is that often, I'd be encouraging both liquid biopsy and tissue sampling. And some of that is to ensure that RNA sequencing can be done to make sure that we're identifying at a high enough sensitivity those FGFR2 fusions and chromosomal rearrangements. And also when it comes to, at least on the FDA side of things, in terms of the approval for things like HER2 targeted therapies, these are, and also for studies that are looking at HER2 therapy, they're still often using IHC criteria, which require tissue to perform that type of analysis. Okay. So again, here's an overview of the growing list of targetable mutations, particularly in the intrahepatic cholangiocarcinoma subtype, as well as the relative incidences of these. And I'm going to get more into FGFR2 and HER2 on subsequent slides, but this is just an overview of kind of the key actual molecular features and notable trials and agents that can be used in these scenarios after Genesis immunotherapy in the first line. And so these are coming more into play in the second line or later setting, and sometimes considerations are being made to move them up to that maintenance setting after establishing good disease control with the induction period of Genesis durva. So to just go into a little bit more detail specifically for FGFR2 fusion rearranged patients with biliary tract cancer, there's two currently FDA approved FGFR inhibitors, pemigatinib and futibatinib, relatively similar clinical outcomes, about 40%, a little bit less with pemigatinib. Objective responses, you see that the median PFS and OS are slightly more favorable to futibatinib. I tend to be using futibatinib more, and that is because of its irreversible covalent binding mechanism that should hopefully address some primary resistance features that may be less responsive to pemigatinib. There are other newer and novel ways of inhibiting FGFR in these patients. There is the very selective FGFR2 inhibitor, lirafugratinib, that has shown really some excellent clinical efficacy. It does come with a trade-off of having higher rates of hand-foot syndrome, stomatitis, and nail toxicity compared to the pan-FGFR inhibitors. And then there's going from very specific to just more of a novel mechanism of pan-FGFR inhibition is tenigatinib, which is really being groomed to be the hopefully the next step after a patient progresses on something like futibatinib or pemigatinib. And we're seeing in these cases that those FGFR inhibitor experienced patients can still have disease control, or 20+% chance of objective response when treated with these novel FGFR inhibitors in a later line setting. And just to make a comment here, we're talking with tenigatinib, and again, this is a patient that's already seen first line chemoimmunotherapy, has already seen one FGFR inhibitor, and hopefully gotten benefit from that. And when they're treated with tenigatinib, there's at that point, from then on, they're getting a median OS of 17 months, which is really fantastic to be seen. Okay. The first 308 trial is currently getting close to finishing accrual, and so hopefully we'll have data reported out on that soon. And this is specifically looking at patients that have already progressed through one line of FGFR inhibition, and so hopefully we will be able to standardly start having a standard option for FGFR sequencing in these patients. Okay. Now, chemosparing does not mean without side effects. And when it comes to the pan-FGFR inhibitors, you really have to be keeping an eye out for nail toxicity, hand-foot syndrome, hyperphosphatemia, diarrhea, nausea. So these are certainly not side effect free, and some of these, particularly in my experience, the hand-foot syndrome can be quite quality of life limiting and certainly dose limiting. There's very, very good guidance on the management of the hyperphosphatemia, and I think that's often seen and often need to make dose adjustments, but usually that can be quite easily managed. But when it comes to patient experiences, it's the hand-foot syndrome and the nail toxicities that, also that the stomatitis, but a little bit less so, that I see are really the main quality of life limiting side effects with these medications. So just things to be aware of and stay on top of. And also a little bit deeper of a dive into the HER2 targeted space. And we have numerous ways of targeting HER2, thanks to the acceleration of drug development in other cancers. And that can be from a single epitope monoclonal antibody drug conjugates, bispecific antibodies, and small molecule inhibitors. And here's a table really kind of giving an overview of the experience of HER2 inhibition or antagonism when it comes to biliary tract cancer patients. And right now we've got two FDA approved agents, one with a tumor agnostic approval and one biliary tract cancer specific, and that's zanidatamab, that can be used in this space. And I think what is important to highlight here is that really the benefit is mainly for the IHC 3+ biliary tract cancer patients. We're just really not seeing much effect in those that are HER2 IHC 2+ FISH amplified. So really all the more reason to be making sure that we get tissue to do the proper IHC characterization for these folks. And just to compare our two approved agents, so we have trastuzumab deruxtecan and HER2 ADC versus zanidatamab, which is a bispecific, and one has a chemo component. I think that's probably the biggest the difference between the two, where you're going to have more chemo-related or chemo-similar side effects with trastuzumab deruxtecan, and you don't have a chemo component with zanidatamab. There's going to be more diarrhea with the zani. It's almost like giving Herceptin and Perjeta together, but just as one molecule, and more infusion reactions. But with proper pre-medication, that should not be an issue, or at least not a significant issue. So just things to keep in mind. And of course, in HER2, we're seeing more of the ILD pneumonitis, which, although rare and getting better recognizing it and should be less of an issue with a lower dose, can still be potentially deadly. Okay. And just in terms of things to be looking forward to, we're got numerous agents trying to exploit the vulnerabilities of MTAP loss, MDM2 amplification targeting agents, and of course our RAS inhibitors, and with the specific KRAS G12D inhibitors, which will have a major impact on biliary tract cancer, as well as obviously other primaries, most notably pancreas cancer, but biliary tract cancer will get a large boost should those be panning out. And finally, I'm going to not do this topic justice because it would be a complete talk within itself, but I did want to touch on systemic therapy just briefly when it comes to the resectable disease population. Okay. When it comes to systemic therapy in the adjuvant setting, the gains have been limited to mainly adjuvant capecitabine, and the absolute benefit of that is still relatively modest, but we have not found a better option at this time, and it is certainly an area for improvement. But for right now, any patient that is a candidate for chemotherapy and is open to getting chemotherapy following resection, particularly if there are zero, I do offer adjuvant capecitabine. I reserve chemoradiation specifically in cases of R1 resections, and this is based off the SWOG S0809 study that was specifically looking at folks with extrahepatic cholangiocarcinoma and gallbladder cancer that were at particularly high risk of recurrence, and it's in these types of patients, but really mainly if they're R1, so not if they're R0 and node positive, but really R1 resections. I will offer either this treatment regimen or a modified version that does include both chemotherapy for an initial 3 to 4 months, followed by chemoradiation. Because of the modest benefits that we do see in the adjuvant setting, it rationally makes sense to be trying to see if there's going to be more an impact in a perioperative or neoadjuvant setting. And the results from NeoGULP, and even though gain was underpowered, there's a clear pattern that upfront 3 months of systemic therapy, chemoimmunotherapy is providing a survival benefit in well-defined high-risk resectable patients. And I think that well-defined are the key word, is the key term there, where the future of these studies and its applicability in the clinic is really going to ride on a clear definition of resectability and high-risk features when it comes to biliary tract cancers as a whole, but really each anatomic subtype within these groups of diseases. And generally speaking, if someone is a T3, T4 node positive gallbladder cancer and they're in my clinic, I'm going to be thinking about a regimen that's similar to what was done in POLCA-GB with chemoradiation in combination with perioperative GEM doublet chemotherapy. But more generally speaking, if there are high-risk features like these listed on here, and the surgeons are particularly worried about the ability to get an R0 resection, I think it's very reasonable to be giving 3 months of gemcitabine, reevaluating them for surgery at that time, and then, assuming resection goes well, R0 resection, doing goal 6 months of capecitabine in the adjuvant setting. And that brings us to the end. Thank you, everyone, for your attention. Thank you to the team at OncoDaily for inviting me to participate. Here's my contact info, and hope this has been helpful for you and your practice.
It's my pleasure to moderate the next session, 10 Commandments in Gallbladder Cancer, with Professor Vinay Kumar Kapoor, Senior Professor of Surgical Gastroenterology at Mahatma Gandhi University of Medical Sciences and Technology. Hello, Professor Kapoor. How are you?
Hello. Good evening.
Welcome to our session. And I want to ask my first question. If you had to decline the first and most important commandment in gallbladder cancer, what would it be?
Good evening. So I'm going to talk to you about gallbladder cancer, that what are my commandments for management of gallbladder cancer. And as has been said, that I work at the Mahatma Gandhi Medical College and Hospital, which is a unit of the Mahatma Gandhi University of Medical Sciences and Technology in the city of Jaipur, which is the capital city of one of the western states in India. And my email address is vkkapoor.india@gmail.com. But why do I say that these are my commandments? What authority do I have to pass on these commandments to the audience? Before I came to Jaipur in 2021, for more than 30 years, I worked at an institution in the city of Lucknow, which is in the North Indian subcontinent, at a tertiary level referral hospital, where we used to see almost 3 to 5 new patients with gallbladder cancer every day. So over 30 years, we had an experience of more than 1,200 operations and more than 700 resections in patients with gallbladder cancer, which probably is one of the largest single institution experiences anywhere in the world. And based on that experience, in the last more than 35 years, we have generated a moderate amount of evidence in various journals related to surgery, gastroenterology, oncology, and basic sciences. So, this large experience and this evidence that we have generated probably gives me some authority to say that these are my commandments for management of gallbladder cancer. We have to understand and appreciate that gallbladder cancer has a peculiar epidemiology. It is not a common cancer in the Western world, which means the United States and Western Europe, where the incidence is as low as 1 per 100,000 per year in women. On the other hand, there are certain geographical areas like Central and South America, Eastern and Central Europe, countries in East Asia like Japan, Korea, and China, where the incidence rates are much higher, ranging from 5 to 9 per 100,000 per year. Even in the US, when we look at different races, there is a difference. Amongst the Native American Indians, the incidence is about 6 per 100,000 per year, which is 6 times the incidence in the Caucasian or the white population or the Black African population. North India, where I used to work in the city of Lucknow earlier, the incidence rate is 10 per 100,000 per year. And in fact, in North Indian women, gallbladder cancer is the fourth most common cancer. The only other cancers which are more common than gallbladder are breast, cervix, and ovary. So it is the commonest non-gender related organ cancer in women in North India. So because gallbladder cancer is common both in Native American Indians and in Asian Indians, I have called it an Indian disease. And in fact, India contributes 10% of the global gallbladder cancer burden, partly because we have a huge population of 1.4 billion, and partly because of this very high incidence of gallbladder cancer, at least in North India. Before we go into the details of gallbladder cancer, it is important that we understand that the suspicion or diagnosis of gallbladder cancer can be made at various stages. It could be obvious gallbladder cancer when the clinical suspicion is high. This would be a middle-aged or elderly patient who has dull continuous pain in the right upper abdomen, has some anorexia and weight loss, may have jaundice, may have features of gastric outlet obstruction, and on examination, there may or may not be jaundice, and there is a firm to hard gallbladder mass which is palpable. So this is obvious gallbladder cancer. On the other hand, if the history is like gallstone disease, but when we do an ultrasound, we see some abnormality in the wall of the gallbladder in the form of thickening or a polyp or a small mass, that becomes a suspected gallbladder cancer. On the other hand, if the history is like gallstone disease and ultrasound shows only stones and the wall is normal, but during the operation, we find that it is not like simple gallstone disease with chronic cholecystitis. That is why what I suggest should be called unsuspected gallbladder cancer, because we did not suspect it on preoperative imaging. And then there are cases where we have completed the cholecystectomy and we have sent the gallbladder for routine histopathological examination with no suspicion, but the pathologist says that there is a malignancy. That is incidental gallbladder cancer. And sometimes we see patients who have had cholecystectomy whose biopsy also was negative, but after a few months they come back with a recurrence because of early gallbladder cancer was missed even by the pathologist. So this is what we call a missed gallbladder cancer. Unfortunately, when we have the symptoms and signs of gallbladder cancer, which make it clinically obvious gallbladder cancer, most or majority of these patients, more than 90% of these patients have advanced disease. And they may already have metastasis either in the lymph nodes in the supraclavicular area in the neck, or as an umbilical nodule, or as a liver metastasis, or malignant ascites, or pelvic deposits in the rectouterine or rectovesical pouch. So in these cases, a thorough clinical examination should be done to look for distant metastasis. Now, if the clinical picture is not suggestive of malignancy and it is like gallstone disease, or if there is a suspicion of gallbladder cancer, the first investigation obviously is ultrasound. And again, some of these cases may show evidence of distant metastasis in the form of space-occupying lesions in the liver, a deposit in the omentum or in the pelvis, and that indicates metastatic disease. If ultrasound does not show metastasis, only suspicion of gallbladder cancer, then the next investigation is a contrast-enhanced, preferably triple-phase CT scan. There again, we should look for distant metastasis such as enlarged aortocaval or left para-aortic node, which are distant nodes. They indicate distant spread of the disease and a poor outcome. If CT does not show metastasis, then the next investigation is a PET scan, again to detect distant intra-abdominal disease and extra-abdominal metastatic disease, either in the lungs or in the supraclavicular node or in the bones and brain. It has been shown that even after the CT shows no metastasis, because gallbladder cancer is a very aggressive malignancy, PET scan may show distant disease and may alter the plan of management in a significant number of cases. So it is strongly recommended that in most patients or in almost all patients with gallbladder cancer, if affordability and cost is not a constraint, it is always a good idea to do a PET scan. Here, pointed by the arrow, we see a small peritoneal deposit which was not detected on the CT scan, and this would indicate disseminated disease. Now, once all these investigations show that the disease is not metastatic, there is no distant disease, the issue is, or the question is, whether we should try to get a tissue diagnosis. But in case of gallbladder cancer, it is recommended not to try to get a tissue diagnosis by doing a trans-abdominal percutaneous FNAC or core biopsy. The reasons are two. Number one, gallbladder cancer is a very aggressive disease, so there is a theoretical risk of peritoneal dissemination or needle tract implantation, which will convert the disease into a metastatic or a systemic disease. The second reason is that, like any other area, the FNAC or core biopsy is not 100% sensitive. So even if it is negative, we would still have to resect based on radiological suspicion. So it is recommended that if the disease is resectable and the patient is fit for surgery, there is no need to try to get a tissue diagnosis. The exceptions are if the disease is inoperable, either because of the stage of the disease or the condition of the patient. If at surgery we find it to be unresectable, or if preoperatively it is locally advanced non-metastatic disease and we want to give neoadjuvant treatment, which I will discuss later, then a tissue diagnosis is required. And some surgeons would like to know or confirm that it is malignancy before they are planning to do a major resection like a liver resection or a pancreatoduodenectomy, because the mortality of these procedures is high. And there is a condition called xanthogranulomatous cholecystitis, which can mimic gallbladder cancer even on imaging. So some surgeons, if the case is suitable for those major operations, may insist on a tissue diagnosis. But then also it is better to do it at the time of laparoscopy or laparotomy, a direct fine needle aspiration cytology, or a true cut biopsy. Now, what is unresectable gallbladder cancer? Why I'm describing unresectable first? Because as I said earlier, majority of the patients in whom the clinical or radiological diagnosis is gallbladder cancer, they are unresectable. So if the proper hepatic artery or the main portal vein is involved, it is unresectable. Unlike cholangiocarcinoma, where vascular resection can still be done. If the pancreas is involved, in most centers now, we consider it unresectable. If the duodenum is involved, we may do a duodenal resection, provided the head of the pancreas is not involved. If any of the distant nodes, that means at the origin of celiac axis, at the origin of superior mesenteric artery, and aortocaval or para-aortic nodes are involved, that they are also considered to be distant disease and make the disease unresectable. It is not technically unresectable, but it is oncologically unresectable because the outcome is going to be poor. What is resectable gallbladder cancer? Is disease confined to the gallbladder, with infiltration of liver, preferably minimal infiltration, involvement of structure which can be easily sacrificed like omentum, colon, maybe duodenum, and rarely head of the pancreas, but that would require a pancreatoduodenectomy. And lymph nodes confined to the hepatoduodenal ligament or behind the head of the pancreas and duodenum. Any nodes beyond that, as I mentioned earlier, celiac, superior mesenteric, and aortocaval, make it unresectable from outcome point of view. Now, once we have found that the disease is resectable and the patient is fit for surgery, before we take the patient for a surgical procedure, we strongly recommend staging laparoscopy, because it has been shown that staging laparoscopy can detect these small surface peritoneal deposits which can be missed on CT scan and even on PET scan. But they can be easily picked up on staging laparoscopy, and then it should be biopsied and sent for frozen section. If it is positive, then one should not resect because the outcome is going to be poor. So with better and better CT scan and more frequent use of PET scan, the number of cases in which staging laparoscopy will show these deposits is decreasing, but it is still significant, and therefore NCCN strongly says consider staging laparoscopy, and we, based on our experience, recommend it as a routine in all cases. Now, if staging laparoscopy does not show any peritoneal dissemination, the standard treatment for gallbladder cancer with limited liver infiltration is what is called an extended or a radical cholecystectomy. It includes the gallbladder with a 2 centimeter wedge, which is a conventional marking. There is no evidence. It could be 1 centimeter, it could be 3 centimeter, depending on the liver infiltration. Lymph node dissection in the entire hepatoduodenal ligament from the porta hepatis to the superior border of duodenum, and then after cauterization of duodenum behind the head of the pancreas and duodenum. So all retropancreatic nodes are removed, and along the common hepatic artery to the right of celiac axis. Not the entire nodes around celiac axis, but at least to the right of celiac axis. So that is what is a standard extended or radical cholecystectomy. And this can be done laparoscopically also with equal oncological results. Now, in liver, it has been shown that whether you do a wedge resection 2 centimeter or you do a formal segment 4B and 5, there is no difference. And the aim is to have a R0 resection. So it depends on the extent of liver infiltration, whether you should do a wedge or a segment 4B and 5 resection. Majority of patients with advanced or clinically obvious gallbladder cancer present with jaundice, which could be because of direct infiltration of CBD or because of lymph nodes in the hepatoduodenal ligament. And most studies have shown that these patients, the resectability rates are low. The chances that we will get R0 resection are less. They may require major hepatectomy and vascular resection. Mortality and morbidity is high and outcome is poor. So many centers think that it is a contraindication for curative resection, but it can be done in highly selected cases and in experienced centers. So what I say that jaundice in gallbladder cancer is like the yellow signal on the traffic signal on the road, which means that you should stop, you should look carefully, and if things are all right, then only you should drive ahead. So patients who have extensive liver infiltration or patients who have involvement of the right portal pedicle or patients who have biliary obstruction may require a major liver resection, which includes a right hepatectomy and segment 4, for making it extended right. And because of the aggressive biology of the disease and because of the extent of surgery, the mortality is very high. It is almost in double figures, except one report where they did about 30 cases without a mortality. And most of the major liver resection reports in gallbladder cancer come from Japan. And the 90-day mortality in a very recent report is almost 13%. Surprisingly, the mortality of liver resection for HCC is not that high. And this is because of the difference in the biology of the two cancers. If the head of the pancreas or a major part of the duodenum is involved, especially the second part, then what is required is a hepatopancreatoduodenectomy, because on one side the tumor has gone into the liver or into the right pedicle, and on the other side it has gone into the pancreas or duodenum. And the combination of a major liver resection with pancreatoduodenectomy is called HPD, and this also has a very high mortality ranging from 20 to almost 50%. And the number of actual patients who survived 5 years is very, very small. So that is why Nagoya University, which probably has the world's largest experience with HPD in gallbladder cancer, they say that their results are not satisfactory. And they say it is controversial because of extremely poor survival. It may be done in cholangiocarcinoma, which is involving the intrahepatic as well as the intrapancreatic bile duct. But then cholangiocarcinoma, which I call a distant cousin of gallbladder cancer, has a less aggressive biology, whereas gallbladder cancer is a very aggressive biology disease. So what we say that between the Japanese aggressive approach to gallbladder cancer and the Western very nihilistic approach, where even early gallbladder cancer is not treated adequately and properly, resulting in poor survival, we should have what I call an Indian Buddhist middle path. What is the middle path? That we should be aggressive towards early gallbladder cancer, which, as I will discuss, is usually incidental. And for advanced gallbladder cancer, major resections do not give good outcome, and therefore those patients we should not aggressively surgically handle. Now, after resection, most patients will require adjuvant treatment. Even those who have an R0 resection, if the disease is advanced like T3 or node positive, patients with papillary tumor, because they are more likely to be multicentric, and those with poor histological features like lymphovascular or perineural invasion, and in case of an incidental gallbladder cancer, if there was bile spill. So evidence in favor of adjuvant therapy is moderate, poor and very poor for chemotherapy, chemoradiotherapy, and radiotherapy alone. So it is mainly chemotherapy. As I mentioned, large majority of patients with gallbladder cancer are not resectable, but they need palliation from symptoms of biliary obstruction and gastric outlet obstruction and pain. But today, if expertise and equipment and facilities are available, the palliation is purely non-surgical. It is endoscopic, biliary and gastroduodenal stenting, percutaneous, if the block is very high in the biliary tree, and EUS-guided celiac plexus block for the relief of pain. And this then can be combined with chemotherapy. A word about incidental gallbladder cancer, which, as I mentioned, is a situation where clinical history was of gallstone disease. Ultrasound showed only stones, no abnormality. We completed lab chole, and grossly the gallbladder looked normal. There was no abnormality, and we sent it for routine histological examination. And now the pathologist says that there is malignancy. So most of these cases are early, and almost all of them probably would require what is called a completion extended cholecystectomy. We have to go in again, take a part of the liver wedge, like I said earlier, all the lymph nodes. CBD may or may not have to be excised depending on the location of tumor and the cystic duct margin. Earlier, we used to do port site excision, but now most centers do not recommend port site excision. There is a huge controversy about when this reoperation should be done. Time doesn't allow me to go into these details, but one philosophy is that do it as early as possible once the patient has recovered medically, financially, and emotionally from the previous surgery. The other option is to give some adjuvant treatment, 2 or 3 cycles, reevaluate, and then do the reoperation. In areas where gallstones disease is very common, we very frequently see what is known as a thick-walled gallbladder, when the ultrasound shows that the gallbladder wall is more than 3 millimeter thick. All these cases should be evaluated by CT. If the thickening is focal, non-uniform, asymmetrical, that is a strong suspicion of gallbladder cancer, and these patients should be treated like gallbladder cancer with a formal, extended, or radical cholecystectomy. On the other hand, if the thickening is uniform, regular, symmetrical, as is shown in the CT scan here, this is more likely to be benign, xanthogranulomatous cholecystitis. So in these cases, we recommend that it should be what is called an anticipatory extended cholecystectomy. We remove the gallbladder with a 5 millimeter to 1 centimeter wedge of the liver parenchyma. So the dissection plane is not between the gallbladder and cystic plate. It is outside the cystic plate in the liver parenchyma. And then we subject the specimen to frozen section. If it is negative, as it should be in majority of the cases, nothing more needs to be done. If it is positive, then we add a lymphadenectomy to complete the extended or anticipatory cholecystectomy. Now, a large number of patients with gallstones, because of routine use of ultrasound for various conditions during pregnancy, are found to have stones which are asymptomatic, silent stones. The question is that what should be offered to these patients? According to data from the Western world, where gallbladder cancer is not common, the recommendation is very clear and very strong that nothing should be done, because the chances that these patients will develop a cancer are very, very low, and even lower than the risk of cholecystectomy. But in high incidence areas or in populations where gallbladder cancer is very common, like North India, we do it selectively. So if the patient is very young, if it is a large stone, if the gallbladder is packed with stones, because these are risk factors for malignancy, and if there is family history of gallbladder cancer, sometimes we do offer what is known as a preemptive cholecystectomy. Although I must say that this cholecystectomy should be done by a very experienced surgeon to make it more than 100% safe, so that there is no risk of bile duct injury and bile leak. What is required is something like this, that we need to find a serum or a genetic biomarker which can predict a very, very high risk of gallbladder cancer, like this family who has undergone a total gastrectomy because they had a gene which predicted a very high risk of stomach, and then it becomes a preemptive cholecystectomy. We know that this patient is almost likely to develop gallbladder cancer, but as of today, we do not have that kind of a biomarker or a genetic marker, and research is going on in that direction. So finally, I would say that we call carcinoma stomach as the captain of cancers. We call carcinoma pancreas as the brigadier of all cancers. But after having seen all the GI and HPB cancers, I feel that gallbladder cancer is the worst cancer which anyone can have, because it has a very aggressive biology. In spite of doing major resections, achieving an R0 resection status, the outcome of these cases is very poor. The only cases where the outcome can be good are which are detected early, and most of the early cancers are detected as an incidental gallbladder cancer after we have done a laparoscopic cholecystectomy for a presumed diagnosis of gallstone disease, and the pathologist says that it is gallbladder cancer. So that is why I said that we have to have an Indian Buddhist middle path, that for these early incidentally detected gallbladder cancers, we should have a very aggressive approach, because that is the only chance for cure. Whereas for locally advanced gallbladder cancer, although technically we can do major procedures and achieve R0 resection status, the outcome is not very good. Finally, a word for my young colleagues who are working in areas where gallbladder cancer is common. These are the areas which you should take up for research. Try to establish a gallbladder cancer registry in your area, in your region. Study the natural history of asymptomatic gallstones in your population by following up these patients to know whether in our areas, in our ethnic groups, there is a high risk of gallbladder cancer. Then we will be on a firmer footing to advise a preventive cholecystectomy. The role of PET scan in staging is almost established, but that is another area where you can look into it, that in which cases PET scan should be done. The role of neoadjuvant treatment in locally advanced non-metastatic gallbladder cancer, and now along with adjuvant chemotherapy, any immunotherapy, whether it will help. Is there a difference in gallbladder cancer with and without stones? Because in our population, almost 20 to 30% of patients with gallbladder cancer do not have stone. Role of screening and preventive cholecystectomy, and basic research to identify biomarkers, establish cell lines and animal models for gallbladder cancer. So since I have not been able to cover the entire knowledge about gallbladder cancer in this presentation, I would request that you can ask your department or institution to obtain a copy of this monograph, which has been written by me, but each chapter has a commentary by experts from all over the world in the area of gallbladder cancer. For the students in the audience, we do an online surgical class every Saturday, 9 to 10 a.m. Indian time. If you want to join the group, it is complimentary. There is no fee. Please send a WhatsApp message to my colleague, Dr. Anand Nagar. We will add you on the list, and then you will get all the details of all the online academic activities that we conduct for surgical students all over the world. Thank you. Thank you very much.
Thank you, Professor Kapoor, for your presentation. It was very informative and interesting. And thank you for inviting to join with the discussions in Saturday. It was nice pleasure for me. Is there anything you want to add in the end?
No, I could not locate where OncoDaily is located, which country, and I would be very happy to participate in your future academic sessions also.
Thank you. Thanks a lot. It was nice.
Can I leave?
Yes.
Can I leave the session? Thank you.
Thank you. Bye. Hello, everyone. We are back. And it's my honor to present our next speaker, Ghassan Abu Alfa, medical oncologist at Memorial Sloan Kettering Cancer Center and Well Medical College at Cornell University. Hello, Dr. Abu Alfa. We are going to talk about gallbladder cancer treatment.
Yes, thanks so much, Mary, and good to see you, Dr. Erman, and congratulations and thanks for OncoDaily on this opportunity. It's really a great honor and a very pleasant surprise to really join in I like the way this is really brought in, which is how do I treat gallbladder cancer? As you noticed, and as we agreed, we're going to experiment that there's no slides. And if anything, I want everybody to really kind of like pay full attention to what I'm going to say, because I'm going to pretend that I'm in the clinic and I'm just doing things as needed for a patient who's coming with gallbladder cancer or, of course, bile duct cancer. So the important reality is that those cancers were really poorly understood until relatively later on. And we always kind of encompass them all in one group. We call them biliary cancer because they're all coming from some form of the bile duct cancer. And we, if anything, short of any data that really tells us how to treat them, number one, we did not know how to diagnose them. And number two is we just borrowed therapy from other diseases. If any of you will look back into the literature from the 60s, 70s, 80s, there is a reasonable chance that you'll be talking about gallbladder cancer, biliary cancer, specifically biliary cancer, and you're referring to something called cancer of unknown primary. Actually, there is some data that was published that shows actually most of the unknown primaries were actually biliary cancer to begin with. Why is that? Because pathologically, there's no clear signature for the cholangiocarcinoma. It's very hard to delineate and understand, especially because of its neighbor, pancreatic cancer. So always you didn't really know how to connect the two. And that's what brings me to the second point that I have, as I brought in, which is other than hard to diagnose, we didn't know how to treat. And that's why we always borrowed from our neighbor, the pancreas, to see how we treat pancreatic cancer, we treat biliary cancers. Interestingly, this changed markedly with the advent of better understanding how things are to be treated, especially with the advent of the detailed understanding of the microscopic further evaluation, including the now molecular one with the next generation sequencing. And for whatever interesting opportunity that we had with the biliary cancers, they are really flooded with certain genetic sequencing alterations that we proudly and happy we have therapies for. If nonetheless, however, and this is a very important point, as much as I'm stressing out the need for the next generation sequencing, we should not forget that still it might not affect necessarily all the patients. And we still have to know how to treat all the patients. So I always jokingly say to my fellows here at Memorial Sloan Kettering in New York, if a patient is walking down the street coming to the clinic at Sloan Kettering, they should be already talking about getting next generation sequencing. In other words, please, I urge you, whatever you have access to, do it as soon as possible and as early as possible. And why is that? Because it can make a big difference regarding how you're going to treat those patients. Now, on the other hand, though, we should not really lose focus because, as we said, it's not going to necessarily affect everybody. It's going to affect only a number of patients. Now, before we get to therapy, let's just kind of like now that we get a little bit of a big background on where do things stand, like how bad is bad, how common is common. No doubt that there's a better understanding in the whole world in regard to the biliary cancers. On the other hand, however, there's a certain foci of the cancer worldwide that remain omnipresent. And here to delineate two of them in regard to gallbladder cancer, Eastern India and Chile. Intriguingly, till today, nobody knows why. Clearly, there are certain presumed theories about genetic alterations that can cause the development of the gallbladder cancer. And interesting enough, I don't think it's happening anymore, but in India, even I heard from colleagues that in the old days, the teaching was in the schooling that actually maybe mustard oil caused gallbladder cancer. Now this is out. I wouldn't worry about that. But there's still presence of certain genetic alterations that yet to be defined. And the same apply for Chile, especially among the natives compared to the Spaniards. When it comes to cholangiocarcinoma, again, there are certain foci. The most known of is Thailand. But please here, I'd urge you, Thailand is a big country. We should not think about like as big, like as if it's downtown Bangkok. The disease mainly occur in northern east or northeast part of Thailand, which is relatively closer to the other countries like Laos, Cambodia, and Myanmar, and of course, southern China. In those whole region, and this is a very important epidemiological thing, which really urges oncologists to really understand how to interpret this data, because we all have learned it, we all have seen it in the books. Very high common incidence of cholangiocarcinoma in the Thailand area, 1 in 120,000. Wow. And we all get freaked out, thinking like we should never even think of going to Thailand, but that's not the case. What happened in the northeast of Thailand, the population will consume fish from the lakes, and they don't really consume the fish itself. They, unfortunately, because of a very impoverished area of the world in Northeast Island, they probably will take the scrape from inside the fish, while the fancy fish is, of course, being shipped to Bangkok for selling at the big restaurants. And unfortunately, this is a ritualistic thing. They still do till today. And this, unfortunately, brings certain, interventions in regard to the infection that can come along with it, which is mainly aspergillus-based. And these actually lead to certain alterations in the bile ducts that lead to the biliary cancer, especially cholangiocarcinoma. Intriguingly, there has been some data, by the way, which is published already, and I invite you to look at. You will find it easily, comparing even the genetic alterations in the population in Thailand with cholangiocarcinoma compared to other parts of the world. Admittedly, not much of a difference. Maybe you can say a tad off, maybe IDH1 we'll talk about in a second, but really not much of a difference. As such, what I'm trying to tell you is, number one, the disease is probably better understood, is better diagnosed. And interestingly, the third thing I would say, and the last thing, is that there's some field that maybe is kind of increasing in incidence. Why? We're not really clear about that. But of course, we look at all our environment and how we eat, how we sleep, how we do everything. It might have an impact yet one way or the other, but we're not sure of it yet. Okay, so is there any preventive measures? Not really. I think the cautiousness that people can do in their regular life, nothing yet specifically is to really prevent biliary cancer from happening. But are there really thoughtful consciousness component about like symptoms that can occur early? Of course. How a patient with biliary cancer might occur. I would say probably right upper quadrant pain, abdominal pain is one. Jaundice is another because of the bile ducts. And of course, nausea and vomiting. The aim, of course, is the focus is on, can we take it out? Surgery. And if anything, surgical interventions are key. Importantly, data has shown they have to be done by the right people. Why is that? Two important components. Number one, in regard to the gallbladder, I'm almost talking about two different things in parallel, but we'll just keep going back and forth between gallbladder cancer and cholangiocarcinoma. But in regard to gallbladder cancer, number one, the capsule of the gallbladder is so thin that really there's no prevention. There's no serosa that's really preventing the gallbladder from the surrounding tissue. And as such, potential for local recurrence is very high common. And as such, if a gallbladder cancer is of concern, rule number one, please, and this is an important thing, I'm not the surgeon, but I can definitely talk on behalf of my colleagues in surgery, should never be taken laparoscopically. And why is that? Because as you can imagine, the scope, when it goes in, it can be flipped around to look at things, etc. And if you have some cancer cells on the edge of the scope, guess what you're doing? You're flushing it all over the peritoneum. For that reason, it's very important to have appropriate surgery by specialized hepatopancreatibiliary surgeon that will imply taking out the gallbladder and also taking along all the lymph nodes, and thirdly, taking two segments of the liver. Which ones? one right in the middle, segment 4 and segment 5. As we all know, the liver is kind of like very fancy organ. It didn't call itself number. We humans called it. It's really, if anybody knows, the segments of the liver are actually numbered after the way the zip codes or the mailing codes are in Paris. Because in Paris, if you've been, you'll look at that, like at the center of town is like what they call arrondissement, or the surrounding number 1. And then you go 2, 3, 4, 5, 6, and keep going out like a snail. And that's why like Eiffel Tower is like number 16 right here, and 1 is right there. And the liver is same thing. Codate is number 1. If you want to act smart, just say codate is number 1. It's always there. And then the left side of the liver is actually number 2 and number 3. And then you go back now to the right side of the liver, 4, 5, 6, 7, 8. And that's why 4 and 5 you see right next to 4. This is really where they have to be taken out, add to the gallbladder, add to the lymph nodes. When it comes to the cholangiocarcinoma, there's another challenge. Same thing, by the way, a lot of recurrences could occur early. And this is like an alarming thing that I'm sure many of our colleagues who are in surgery, and if anybody is listening from surgery will know that. Satellite lesions. They will always be there, and you don't know what to do. You'll go for the surgery, not go for the surgery. Our understanding here at Memorial Sloan Kettering that they probably are kind of already spread out disease, and there are certain approaches we'll talk about in a second how to deal with this. Great. We had the surgery. Hopefully it's lucky one, and we're good. And we did all things by the book, like take it out as a gallbladder, took out the node, took out the segment 4 and 5 of the liver. We had a great, clear surgery in regard to cholangiocarcinoma. Then what? The chance of recurrence. And for the recurrence, we of course apply what we call adjuvant therapy. Sadly, though, can I sit and say, oh, there's absolute success in regard to adjuvant therapy for biliary cancer? Not really. There are some efforts, there are some studies, there's continued studies, but really we don't have like really the go-to, we can do it like, closed eyes and say, that's it, automatically we should do that. We always debate it, we always discuss it, we always present it to the patients. If anything, you're probably well aware, from the UK, we had the study of the BILCAP study, which looked into capecitabine as a therapy for preventing recurrence of the cancer. And this was probably, if you want to call it as like the extreme to one hand, just like capecitabine, fluoropyrimidine-based therapy, and that's it. On the other extreme, we did radiation therapy plus chemotherapy, and I think the most common of which we keep quoting it is SWOG 0809, which looked into chemotherapy plus radiation therapy, tried to prevent especially cholangiocarcinoma. And of course, from there, we went on and on, we got to different variation of. But you asked me then, what do you do like in clinic on Monday morning? Interestingly, this is the time I spent time with the patient explaining all of this. And to be fair, not necessarily the whole story, but the applicable story, part of the story. For example, if you have a patient who's like 80 years old with gallbladder cancer, I probably would say we all agree that maybe after all good, probably advanced age, but sadly with some poor functionality, are going to be telling us maybe it will be wiser to do some capecitabine or probably observation. On the other hand, if you have like the 40 robust, totally functional lady with the gallbladder, probably chemo-RT or biliary chemo-RT, you can consider that. But also there's new novelties as well, which we're going to talk about quite a bit in a second in regard to systemic therapy. But has there been an intrigue in regard to what about the immune microenvironment that we're affecting so much with all this kind of like crazy inflammation and kind of like activity happening in the biliary environment? Of course, immunotherapy. These are happening as studies. We know very well there are clinical trials. We don't have the data off yet. Looking into chemotherapy plus immunotherapy, same like equivalent to, for example, the TOPAZ study, or even there's like novel, newer approaches of checkpoint inhibitors. But the idea is like chemotherapy plus immunotherapy. As this is like a practical session that we're having together, if I have the access to, do I do in somebody, for example, like in their 60s with advanced, locally advanced, resected, negative margins, negative margins, but with 3 lymph nodes positive, do I do immunotherapy? Yes, I would, if I have access to. And it all depends on like what you have access to, but if really I can, I wouldn't say no. And of course, we'll just wait for the rest of the trials until come on. However, interestingly, still at Memorial Sloan Kettering, and this is in credit to our colleagues who in surgery that we've been working on it together, we don't necessarily believe that the adjuvant therapy is the right approach. It should be what we call, quote unquote, peri-adjuvant, neoadjuvant plus adjuvant. Same as probably Dr. Janjigian showed us in gastric cancer with the Matterhorn study and therapy before and after. Same thing. I think the approach is totally appropriate and reasonable in regard to the biliary cancers. So there's a lot of efforts trying to do those kind of studies. We still kind of struggle to really get it moving, but hopefully we'll have some results one day that will have guide therapy, surgery, followed by therapy. Now, of course, we come to the important reality. Sadly, a lot of the patients either they're going to present with, or they already have, or they unfortunately will evolve their disease into a recurrence, and now they have metastatic disease. How do you treat? I'm always fascinated, and this is like a very important teaching point for us. The ABC02 study that was done by our colleague Juan Valle in the UK and published in the New England could not be any simpler study than this. All what he said, you know what? Let's add cisplatin to gemcitabine and compare it to gemcitabine and see what happens. And all of that, by the way, borrowed from the pancreatic cancer next door, as we just said a second ago. And actually, it showed there is an improvement in outcome compared to having the gemcitabine plus cisplatin compared to the gemcitabine alone, and this became standard of care therapy. By the way, you notice how simple the study is? Still, however, and please, especially the young among us that really are new into this career, the complexity is not necessarily what's going to get you there. The simplicity is really what's going to really make you succeed. And always kind of like, I always like to call it the plain but forbidden field. If you have the plain field that really can make everything looks like so easy, enough that anybody can say, oh, that's stupid, why do you do that? But at the same time, you come with the idea that nobody even thought of. This is really the credit of the ABC's root study. And guess what we do, all of us, without even any question? We do GemCis. Then from there, of course, we go back to the checkpoint inhibitors. And why checkpoint inhibitors? That's really interesting. The liver, by the way, if you know, really look at like really a very, very hot environment where really everything is going crazy in regard to the immune system, the liver. And if anything, the add-on of the checkpoint inhibitors to the chemotherapy made a big difference. Remember though, biliary tumors are cold tumors. They really don't excite your immune system. Always I like to quote it that way. They really kind of like pick up the phone, talk to the immune system, say, guys, you know what, we're friendly, leave us alone, we'll not bug you, don't bug us. And this is exactly what happens. And that's why they offer those chairs called PD-1 and PD-L1, where the T cells falling all over your body sit down and they never touch the cancer cell. And until the chemotherapy excites the environment a little bit more, kind of almost as if like a message to the immune system, guys, that are fooling you. And then anti-PD-1 and PD-L1 will kick that chair out, the T cell will fall onto the cancer cell. And that's why we came in with the combination of the Topaz with the gemcitabine cisplatin plus the durvalumab. And later on, we had also the keynote study with the gemcitabine cisplatin plus pembrolizumab. Now, does it matter which one? Admittedly not. I have to say, like, you know, the checkpoint inhibitors are becoming like, you know, same ice cream of different flavors. That's all what they are. Even though there are certain caveats in regard to one versus the other. But I like more the approach about like, what are we doing, which is more important than which one we're doing. Because in the Topaz, I would say that the idea that we'll give therapy only for 6 months, and then that's it, and keep it only on the durvalumab afterwards, was reasonable. But let's think about like, how did it come about? Like, how did they come with this? They came with this based on the following. Remember, in the UK, which is the only country where really there's actually a price for life. This is their system. We're not going to question that. This is how it is. So they said, we'll treat only for 6 months with the gemcitabine cisplatin and the ABC02 study, because this is how much benefit we can get. There's no more value added to the human life after that. That's how they thought about it. We're not going philosophically into this. That's the nature of it. So interestingly, there's a lot of kind of, temptation to really treat that way. And that's why the TOPAZ study just carried on this. And they said, okay, but I will keep the immunotherapy afterwards. To be fair, though, because remember, when you excite your immune system, you probably don't need to keep exciting it all the time. You can just carry on with the anti-immune checkpoint inhibitors afterwards as well. I confess, though, from my hands-on experience, and this is what we're here for, I remember very well when it was presented, the first patient in my clinic that got the Gemcis durvalumab was actually, if you recall, at GI-ASCO. The presentation was on Friday by Dr. Oh from Korea, and I presented the same day the study of the Himalaya study for the durvalumab. My first patient was on Gemcis durvalumab on Monday. And interestingly, patient recurred. So I learned that actually you have to keep the chemotherapy on. So what I do is I actually keep chemotherapy on even beyond the 6 months. Maybe I drop the cisplatin, but I keep the gem. So I do gemcitabine plus durvalumab. And I'm not trying to claim any credit over here because I give credit for my very dear colleague, Dr. Katie Kelly from UCSF, who actually, when they did the chemo study, they actually did the Gemcis plus Pembro, and they kept the gemcitabine plus Pembro for carrying on forward. And this is really, I totally agree, this is the way to do it. It doesn't matter which one you do it with, but my personal recommendation is Gemcis Durva for 6 months or about. There's nothing perfect here. In other words, if you really get a good, robust, good partial response you're happy with, then Gem Durva. And the Gem Durva, I can keep it to on, one off. And then what I do in practice, I sometimes also change it to once every 3 weeks. And this way people get a little bit of a more functional life, can carry on, etc. And then, of course, if they want to go on holiday for 1 month and come back 1 month, I can live with it. I will become more permissive. And the fascinating things, we've seen complete responses. It's amazing that people can get a complete response from that therapy. Now, what if there's recurrence? And this is really where the next-gen sequencing is going to come into play, but not for everybody. Let's talk about chemotherapy first for a second, and then we'll talk about the checkpoint inhibitors, and we'll close it up. Number 2, in case there is a recurrence, what else can we do? You remember we had the FOLFOX based on the ABC06 study. We have the liposomal irinotecan based on the NIFTY study. We have the kind of hands-on experience that we did, 3 institutions together, Vanderbilt, UCSF, and Memorial Sloan Kettering in New York, where we did look into FOLFIRI. Any of them will probably help one way or the other. I confess that I have a little bit of an intrigue more into the NIFTY, and I disclose that I was the advisor to the NIFTY study, and I'm actually a co-author on the 2 papers for that in JAMA Oncology. But there's a certain robustness for the liposomal irinotecan that I hope and I wish it will be approved in the guidelines here and there for that purpose. It seems that for whatever reason, the company did not decide to go that route. However, one thing that I would like, and I still can do it if I can, sometimes it's very limited when I can, but if patient progress, would I keep the immunotherapy on? And I do, if I can. And the reason is because, remember, we spoke about that scaffolding of the building, which is the immunotherapy, which is really the robust kind of key. And that chemotherapy you put on is the plaster or like the walls of the building. And then you change walls, but the structure is the same. So as such, is it possible for me, if patient progress on Gemcis Durva, ultimately to keep the Durva, but change the Gemcis to liposomal irinotecan like NIFTY or FOLFIRI or FOLFOX plus Durva? I do. And amazing, sometimes get really robust responses. So something that I hope we'll get the study for as well. Now, this, by the way, I really spent a lot of time on this because I didn't want to really make anybody fooled as if like genetic testing is going to be like the most thing's going to fix everybody. I confess, I probably was wrong myself even. We were so excited. We said, oh, probably about 50% of patients with biliary cancer are going to have some form of genetic alterations. Well, not really. If anything, the data is telling us that maybe IDH1, a little bit a tad more than what we think, like 10 to 15%. FGFR2, at best, if really you're really optimistic, 5%. and maybe HER2 for the gallbladder cancer, but it had higher, about 10 to 50%. That's it. So, proudly from Memorial Sloan Kettering, we brought to the world also 3 drugs. If anything, we had, like, even if they were happened, like they were published back to back in Last Oncology. If you recall, we have the ivosidenib for the anti-ADH1 therapy, was still robustly standing there, and it's incredible how well it does. Patient can stay on it for years. Incredible. Then we have the anti-FGFR2, the pemigatinib, which also robustly helped quite a bit with people. We have then the beautiful work of futibatinib that Dr. Nikhil Agrawal, who's now at Stanford, brought to us. And then, of course, we have along that path also the infigratinib that proudly my colleague Billy Javli and myself from MDS and Memorial. By the way, I say, like, we don't compete. We were together, and we did the study together, but we could not finish a phase 3 trial, which we'll talk about in a second. And then, of course, you heard too proudly the work of my dear colleague here at Memorial Sloan Kettering, Jim Harding. So these are how options are available for you. Now, interestingly, though, and this is a great important closure for all of this, we were excited, all of us. And I can tell you that when the infigratinib were about to move forward with, we really opened a phase 3 clinical trial to look into infigratinib versus placebo, see what happens. We actually screened close to about 1,200 patients. By the way, this was published as a poster at ASCO. And then we were able to treat only about less than 100 patients. We could not complete the study. Because remember, if you do the math, with only 5% of patients have the alteration, how are we going to even accrue all that study, which is like it take you forever to accrue like 300 to 400 patients. So the study did really fail. And of course, understandably, the business part of the companies would say, you know what, it's not worth investing into. We'll just kind of like hold it. I give them credit though. This was kind of traveled through different companies and got to infigratinib. But ultimately, we said we still have an obligation. And please, this is an important message for all of us. We have an obligation. We cannot just like call it cold and say, okay, it didn't work. That's it, move on. We still owe it to the patients. We did the study. We owe to publish the data. So despite that's like there's no money, we were able still to write the paper. The paper's already accepted. Actually, it didn't really get out yet, but I can tell you already we just did the proofread and it's going to happen any minute. And you'll see it in no time, talking about the aim was not only to show like, okay, this study did not work, but it was an important message about maybe we should look with agencies and governments about how for rare malignancies, rare alterations, how shall we do clinical trial? Really phase 3, or shall we look into some other approach among like a phase 2, looking into some caveats, some alterations or endpoints other than the phase 3 overall survival standard things. Stay tuned, but you'll look at the paper. It's going to come out probably any minute, but this already has been accepted. So with this said, I would say, as you see, there's a richness in regard to the therapy. And I'll close only with one more thing that we do, because I mentioned satellite lesions. At Sloan Kettering, as you know, we have a robust program regard to intrahepatic arterial pump therapy, where we actually do infuse chemotherapy directly, mainly fluoxetine, which is like a activated variant of the fluoropyrimidine, directly into the liver. And already the data has been published. Our colleague Andrea Sersek published on that. And I give credit especially for our head of the hepatopancreatic surgery, Dr. Bill Jernigan, who really led on the effort. And now we're really pushing forward for more of that effort to see how we can help per se. One kind of caveat is this: managing a pump is not as easy as one might think of, but I give credit. A lot of colleagues, wherever they are in the world, are doing this. To that merit, we have Dr. Bass in the Netherlands. We have Dr. Witzel in Mexico. And I'm talking all about the international physicians. And we have also, the group with Dr. Shamsuddin and Dr. Muhammad Sani, who's proudly was our fellow here at Memorial and graduating back to the American University of Beirut in Lebanon. And they're doing pump therapy. So clearly it can happen. If any of you are interested, talk to us. We'll see and we'll guide you how to do that as well. In summary, we don't wish those patients to anybody, but thankfully we did a lot of work here. Surgery takeout, adjuvant, neoadjuvant still in the works. systemic therapy plus immunotherapy, and of course, look at genetic alterations right from day zero, so you have options available for your patients. I'll pause here and I'll pass it back to Dr. Gaiman. Thank you.
Thanks, Dr. Agrawal, for an interesting aspects from your practice, and hope that in the future we will have more improved management of rare cancers like gallbladder cancer. Do you have anything that you want to add as a finishing message?
No, thank you so much. Really, I give you credit. This is a great opportunity. I really thank the OncoDaily for giving us the opportunity to really relay how we function. I would love very much if anybody has any feedback on purpose, and I already told the team at OncoDaily that I will not show slides because I want people to live the story. Because otherwise we're just, I know this, I know that, but I want to give really the hands-on. But anybody has any feedback on this, I would love to hear for sure.
Thanks again. Thanks for sharing your experience.
Thank you very much.
Have a good day.
Take care, everybody. Bye.
Bye.
Take care. Bye. Bye.
Thank you so much for staying with us. We continue our webinar with James Harding from Memorial Sloan Kettering Cancer Center. James Harding is a medical oncologist and a researcher who will talk about the biliary tract cancers, emerging AGR2 and RAS-targeted therapies. Thank you so much, Dr. Harding, for joining us and sharing your insights. The stage is yours.
Thank you so much, OncoDaily, for the kind invitation. It's a pleasure to speak with so many experts in the field, and I look forward to talking briefly about emerging therapies that target HER2 and RAS in biliary tract cancers. Here are my disclosures. And as we've heard throughout the sessions today, biliary tract cancers are comprised of intrahepatic cholangiocarcinoma, extrahepatic cholangiocarcinomas, and gallbladder cancers. And although many of these diseases are treated in a very similar fashion, we know that they are clinically distinct, and importantly, they are genomically distinct. And so these are data from Darren Kauser when he was at Memorial Sloan Kettering Cancer Center, where we have an ongoing genotyping project that this data cut looked at approximately 1,200 patients with biliary tract cancers. And you can see genomically, these are distinct entities. And the two targets of interest that we're going to talk about today, both HER2 or ERBB2, as well as KRAS, are expressed in all anatomic subsites, but there's differential expression. So for HER2, we particularly see enrichment in gallbladder cancers, whereas for RAS, particularly KRAS, enrichment in extrahepatic cholangiocarcinoma. In addition to being able to look at tumor genomics, we are able to evaluate these important gene drivers using cell-free DNA. Also by Darren Kauser, this work looking in our enlarging data set of 170 patients with available cell-free DNA, indicating that indeed we can detect these alterations. And there is, in general, a nice concordance with the tissue-based metrics. It's higher for single nucleotide variants, lower for amplifications, and lower for fusions. So we do need, when genotyping biliary tract cancers, we need to keep that in mind. We may need to use a multitude of different testing. And so in my practice, I will often use both immunohistochemistry for HER2, which is reflex testing and required now. We also will do next generation sequencing of the tumor, and in a complementary fashion, look at cell-free DNA to try to triangulate the optimal mutation pattern. We may also use RNA-based technologies to better assess fusions in driver-negative tumors. And so in current standard, or the way we treat advanced biliary tract cancers is generally with gemcitabine, cisplatin, and an anti-PD-1 or PD-L1 therapy. In the second line, if there's no target, we'll use cytotoxic chemotherapies. And for those with mutational targets, we will try to match with a specific precision medicine. And I'll talk mostly about HER2 today, and then towards the end, they talk about emerging strategies in KRAS. The important thing that you can understand, though, is clinical trials are critical. All guidelines recommend clinical trials if they are available, given that our current standards are effective but remain suboptimal, and thus we must continue to advance the field. So the first question always becomes, is HER2 even a target in biliary tract cancer? And I thought these were two nice historic papers in the treatment of biliary tract cancer to illustrate especially that clinical science is indeed iterative. And so these studies, which were conceived over 20 years ago, looked at lapatinib, which was a weaker HER2 TKI in biliary tract cancers. These studies really did not select for HER2 and indeed showed no evidence of anti-tumor activity. So at the time, there was some question, is HER2 even a target? So it's important that we use the right molecule and have the right bioselection strategy. And to the credit of the authors, they did acknowledge this in their discussions. But now, flash forward 20 years for HER2, yes, HER2 is a target in biliary tract cancers. We know in normal signaling, HER2 is a one of four receptor tyrosine kinase. It doesn't have a natural ligand and typically dimerizes with one of the other HER receptor proteins, leading to activation of RAS and PI3 kinase signaling. It's very rare that HER2 self-dimerizes, and in states where there might be ERBB2 amplification leading to HER2 overexpression, there may be signaling via that pathway. We also know that there are single nucleotide variants that are indeed activating. And as a result of these mutations, there's been an extensive look at a variety of molecules over the last 20 years, from monoclonal antibodies to TKIs, and in recent times, antibody-drug conjugates and bispecifics. And this advancement in the field has led to advances for patients. And I'm going to speak with you about a few of those during the next 15 minutes. But before I do that, I want to emphasize that HER2 detection is critical for all patients with biliary tract cancers, irrespective of anatomic subsite. And we must still do immunohistochemistry. And so these data that I'm showing you here are from the Horizon BTC01 study, which I was co-lead with a variety of investigators across the globe. Here I'm showing you our screening analysis, where we looked at 756 patients over the course of the study. Patients submitted tissue and locally were tested for amplification by an ISH assay, followed by an immunohistochemical assay. And the key punchline is that for HER2 IHC3+, 94% of these are indeed amplified as well, but some are not. And it's the HER2 IHC3+ where most activity is seen for HER2 targeted therapies. In addition, we can see that there are 158 amplified patients, but it's only about 27% that do not actually have HER2 overexpression by IHC, where the responses are indeed less. And when we look at cell-free DNA-based assays, although this was an older assay, the concordance is even lower. So at this time, we still need to invest in understanding IHC, and that should be done for all patients. And so let's move to Horizon BTC01. This was a pivotal study that evaluated zanidatamab. Zanidatamab is a HER2 bispecific that targets two specific sites on the HER2 protein. And the molecule, as can be seen in the cartoon, has asymmetric antigen binding domains, right? The FC portions are different size, and this leads to a specific intrans binding that leads to receptor antibody clustering, internalization, HER2 downregulation, inhibition of a pathway, and also appears to activate some immune-mediated responses like ADCC, as well as cytotoxicity related to complement and phagocytosis. In a prior phase 1 study, zanidatamab was assessed as safe and had anti-tumor activity across a variety of tumors, including biliary tract cancers, and this led to the design design of Horizon BTC-01. So this trial enrolled patients with advanced biliary tract cancers, required HER2 confirmation by central lab. They had to have progressed on a prior gemcitabine-based regimen and no prior HER2-targeted therapies, with a primary objective of assessing confirmed objective response rate by an independent central review. The study was set up such that there were two cohorts. Patients were confirmed amplified centrally and were placed in cohort 1 if there were IHC 2 or 3 plus, that was considered HER2 positive, and a cohort 2 which was IHC 0 or 1 plus, traditionally would be considered HER2 negative. Patients then received zanidatamab at 20 mg per kilogram IV every 2 weeks. This was done on day 1 and 15 of a 28-day cycle. Secondary endpoints can be seen. And, here is just one example of one of the kind of immediate responses or a typical response that we might see. 50-year-old woman, stage 4, extrahepatic cholangio, extensive pulmonary metastasis, live-angitic spread, progression on frontline therapy, not tested at that time for any biomarker. Came to see us. We did our typical screening strategies and identified HER2 overexpression and started zanidatamab. And you can see a marked response that was ongoing for greater than 11 months. But when we look at the totality of the data from Horizon BTC-01, this is the waterfall plot for the cohort 1 80 patients. You can see that color-coded based on anatomic site. Asterisks indicate HER2 IHC 2 plus, non-asterisks IHC 3 plus. And what you can see is that more than 60% of the patients on study had some degree of tumoral shrinkage. You can see that there was a response irrespective of anatomic site. And indeed, the objective response rate was approximately 40% in this clinical trial. And what you can see from the Fisher plot on the other side of the graph is that indeed this didn't make a difference based on anatomic site, but it does for immunohistochemistry. IHC 3 plus had a 51.6% response rate in this cohort of 80 patients, IHC 2 plus a 5.6% response rate. So some activity in that cohort, but not as substantial as the IHC3 plus. We have extended follow-up from the clinical trial, which was recently published in JAMA Oncology. And what I'm showing you here is the overall survival for the total cohort in blue. That's 15.5 months, which is quite favorable in a second-line plus setting for patients with biliary tract cancer, especially given that there are data that HER2 overexpression may indeed have a negative prognostic effect. But what's important is if you break this out based on immunohistochemistry, the IHC3 plus have an 18.1 median overall survival versus an IHC2 plus of only 5.2 months in that cohort. On the other portion of the graph, you can see the typical side effects of zanidatamab, which are typically on-target HER2 effects like diarrhea, all low grade, all manageable. Unique toxicity to the regimen is infusion-related reaction. This does require pre-medication, but again, low grade and often does not preclude continued treatment. A very small proportion of patients on Horizon BTC-01 ended up discontinuing zanidatamab. And so presently, based on this data, zanidatamab has been conditionally approved by the FDA, has an EMA recommendation, and has a conditional approval in China, indicating that regulators view it as a potential treatment for advanced patients with HER2 positive IHC3 plus biliary tract cancer. But in order to move the field forward and confirm these findings, Horizon BTC-302 is ongoing. This is a critical study as well. This will again look at advanced biliary tract cancer, HER2 central confirmation of IHC3 plus or 2 plus with amplification, treatment naive, randomization between standard GemCis immunotherapy versus GemCis immunotherapy and zanidatamab, open label trial. with a primary endpoint of PFS in the IHC3+, given that unintentional crossover will undoubtedly occur. Key secondary endpoint will be overall survival. An important aspect of this is that the study does allow 1 to 2 cycles of GemCis immunotherapy prior to enrollment. The study is ongoing, actively accruing at multiple sites across the globe. The other player in this space is trastuzumab deruxtecan. This is Destiny Pan-Tumor02. Here, this was looking at an antibody drug conjugate with a TOP1 warhead, a different design looking to assess this activity across tumors based not on tumor type, but IHC scores. And for the biliary tract cancer cohort, we can see that the objective response rate was about 37%. But when you pull out the 16 patients with IHC3+, we have a 56.3% response. So similar to Horizon BTC-01, HER2 IHC matters. And in this study, you can clearly see that in the underlying site of the tumor may play a role in whether or not biomarker selection is important. So IHC2+ really doesn't respond well in biliary tract cancer, whereas it does, of course, for endometrial cancer. And so we need to clarify this. Based on these data, there's a global phase 3 study, Destiny BTC-01, that's looking at a similar patient population to the Horizon BTC-302 study, where these patients also treatment will enroll looking at 3 different arms: standard GemCis Durva versus TDXD alone versus TDXD with a novel bispecific rilvegostomig. Primary endpoint is the comparison of A and C based on a survival metric in the IHC3+. So don't have time to go through all of the studies, but for your reference, there are a number of HER2-targeted phase 2s or baskets that have been conducted with variable response rates. Really, the summary, the activity appears to be in the IHC3+. We don't understand as well the IHC2+ population. Work is ongoing there. And single nucleotide variants have response rates to TKIs and other HER2-targeted therapies, but this is still with an area of clarity that needs to be defined. Zongertinib is looking at this space now on a basket study. And so a critical component is we know resistance occurs. We've published extensively on this, and this is multifactorial. We see HER2 loss at progression, see a number of other mutations that may reactivate the MAP kinase pathway. And presently, we have a large effort at Memorial using a kind of a multi-omic approach, starting from the patient, looking at functional imaging, all the way down to the single cell. And we'll talk more about that work at a later time. And so, pivoting in the last 5 minutes, biliary tract cancer is still largely undruggable, but the MAP kinase pathway represents about 20% of abnormal activity in biliary tract cancer. And to date, we've only been able to drug a small portion of that. Those patients with BRAF V600E respond well to combinatorial to combinatorial RAF MEK inhibitors. That's been demonstrated multiple times. We also know that KRAS G12C, which is less than 1% of the population, can be drugged with adagrasib. There's huge excitement now, though, in all of oncology in drugging RAS, utilizing the unique biology of RAS and how it is turned on and off. With a novel chemistry, you can inhibit these pathways with pan-RAS inhibitors, selective off inhibitors, mutant allele-specific inhibitors, and that's what we'll discuss. Just for your records, here's targeting BRAF, really a robust response of 51% with dabrafenib and tremetinib, favorable PFS and OS. But the emerging space, of course, is RAS. And here's some data from one of our manuscripts in review. 17% of biliary tract cancer
patients are KRAS mutated. You can see the breakdown there. Adagrasib, as I mentioned, is the first-in-class proof of principle that we can inhibit KRAS in biliary tract cancer, but there are a number of modalities now ongoing. Don't have time today, but we're also looking at drugging MTAP deletions with PMRT5 inhibitors. MET amplifications have now seen activity with tilasotuzumab deruxtecan, and those studies are ongoing, as well as MDM2 amplifications. The key, though, for RAS is that in addition to having mutations as a primary driver, we see these as acquired mechanisms of resistance. This is from our work recently published in JCO Precision Oncology, not looking at RAS inhibitors, but looking at other targeted therapies. And in 20 paired samples using cell-free DNA, we noted RAS alterations not detected in pretreatment samples were detected in about 25% of patients that progressed on a prior targeted therapy. So building the idea that we might sequence these. So in summary, my conclusions for today: mutational profile is critical in the current age of treatment of biliary tract cancer. We must do HER2 immunohistochemistry, although a validated method has not fully been established. We do use gastric criteria presently. Ongoing work, it focuses on understanding resistance to the approved agents. HER2, we know, is druggable, and pivotal studies to confirm a survival benefit are ongoing. RAS targeting is now on the horizon, but despite this, we're still going to push forward with novel IO, ADCs, radioligands, and protein degraders. I'd like to thank all of the colleagues that helped me do this work listed here on this slide, as well as all of my funders, especially OncoDaily, for arranging this excellent event. Thank you so much, and I look forward to the panel later.
Thank you so much, Dr. Harding, for your time and for an excellent presentation. We are very grateful you joined us and shared your insights with our audience. Thank you so much.
Thank you.
Good evening. So we are coming to the end of our webinar on how I treat gallbladder and bile duct cancers, organized by OncoDaily. And we are here for the most exciting and awaited session of panel discussion. And today we have the honor of having with us Dr. Aaron Perez from Brazil, who is a hepatobiliary and liver transplant surgeon at Universidade Federal de São Paulo. We have Dr. Giuseppe Santa Barbara, who is a medical oncologist at San Giuseppe Moscati National Hospital from Italy. And we have Dr. Lucian Wilwicz, who is the head of Department of Oncology and Radiotherapy at National Cancer Research Institute in Warsaw, Poland. Thank you for accepting our invitation and being today with us. We are very happy to have you on board. And I believe I should briefly introduce myself. I'm Amalia Sargsyan, a medical oncologist from Armenia, and I am also the VP of Research at OncoDaily. And because we have both a surgeon, a medical oncologist, and radiation oncologist here on board today with us, we'll try to make it more broad and just have your ideas on how do you see the treatment of bile duct cancers today and in the future, what has changed, and how do you usually do in your daily practice, because we have very broad representation from different countries. I think it will be nice to hear who is doing what and has what kind of accessibility in their daily clinic. So maybe I can have a question and you start sharing with what you do in your daily practice, what is available in your country. If you would like to format, please feel free to make it interactive if you have any comments or would like to ask a question to each other. So it's very flexible and not very strict. I guess for a start, yes?
Yeah, please.
So for a start, maybe we can start from the first part when the patient comes to you and you see in the clinic a metastatic bile duct cancer. What will be the first panel you will check for them? Is this available to do NGS broad for metastatic patient upfront, or do you prefer doing only some molecular markers? How would you approach? Maybe we can start one by one. Who would like to start?
I can start how it's in our practice. So from treatment availability, we have immunotherapy for the first line. setting, and we have some molecular targeted agents, but they are restricted more to further lines. So we often start with the treatment of the first line. During that time, we do molecular. This is related with the current availability of the drugs. For the research purposes, if the patient is in stable situation, we do NGS before start. But if the patient has rapidly progressing disease, then we start first line without doing major NGS, since we only immunotherapy line.
Dr. Santa Barbara?
In Italy, there is some kind of problem because we would like to have NGS at the diagnosis or just before, just post operation, just post surgery, or but more really when the patient became in metastatic state, and we just Lucian start with immunotherapy and chemotherapy for the first line, and test the NGS during this treatment. And at this moment, we don't need to wait the NGS results to do immunotherapy. So we collect this information for the subsequent line of treatment.
So for the first line, you start with the standard, which is available everywhere, and then you wait for the results. And based on the results, can you adapt this? So you will give another targeted treatment if you find any kind of mutation. So you will do NGS at the end for everyone, right? If not rapidly progressing. This was your point.
Oh yeah, yeah. In Italy, we have only the ivosidenib and pemigatinib at this time for subsequent line. For us, zanidatamab, trastuzumab deruxtecan, or pertuzumab or trastuzumab is not permitted to use at this moment. Only in clinical trial, and not all centers have clinical trial to track these patients.
Dr. Aaron, I would like to ask you, so a lot of things change nowadays. We are having more and more treatments available, novel agents, and I believe a lot of times used to be non-resectable patients sometimes become resectable a bit more nowadays. What has changed in terms of surgery? Do you see more patients going on operations, or what is the biggest change you see in the last 5 years, and how do you see it changing for the other 5 years? In a lot of cancer treatment, neoadjuvant treatments are becoming hype, not here yet, not that much as in other cancers, but how do you see the changes of this, even molecular subtyping changing your role as a surgeon in treating those patients?
Okay. Thank you for the question. Just to start, I would like to start thanking OncoDaily for the invitation. It's really a pleasure to be here with all of you and being able to discuss about this. So I'm based in São Paulo, Brazil. And in Brazil, we have a very particular situation. We deal with two medical systems that are completely different from each one. We have a public health system, and we have private health system. And about 75% of the population in Brazil, they depend exclusively on public health system, and the other 25%, they can use the public health system, but they also have private insurance. So in the public setting, it's a big problem in terms of access and molecular diagnosis that we were talking in first. So we usually don't have access to NGS,
and immunotherapy in public health system. But in the private setting, we can do it. So NGS is very often available, and also all the new immunotherapy regimens. And so the goals for surgeons is very different in which setting you inserted in. Like in public setting, the goal is to try to get the patient to the operating room as soon as possible, because these patients are usually take long time for diagnosis and to be able to get to treatment. So the big deal is like timing. But in the private setting, where we have all the armamentarium, so I think this is the point where the immunotherapy really came with some changing, and we're really seeing some patients that wouldn't be resectable coming to resection, and this is very interesting. And also some patients that are resectable but are deemed high risk. We are looking forward to more robust results on neoadjuvant therapy to this specific population. I think this will be this is a group of patients that will certainly benefit a lot.
Mm-hmm. Thanks for sharing the insights. So this is interesting to hear, because from system to system, it affects how you start your treatment, because this depends on how much of the availability of the further lines you would have, or even the first line. And I believe these problems have different countries. So it's Italy, Poland, or Brazil, or from Armenia. I think we are facing the same situation. And a lot of things depends on what we are going to offer them. Is it a better one, or we should rush to the surgery because we might lose the chance of operating him now? So another question which might involve, I think, all of you, is where everyone comes together when it's resectable, borderline. Let's imagine a scenario where it's an intrahepatic cholangiocarcinoma R1 resected. What would be your approaches? How will you choose how to sequence the further treatments? I would love to hear comments of all of you, what you will say in this scenario.
You mean R1 resection in intrahepatic?
Yeah.
Well, it depends. We usually collaborate with the best surgeons in Warsaw, so we have a huge liver surgery unit just next door. So if it's R1 resected, then it couldn't be re-resected in most of our situations. We can offer a patient either adjuvant chemotherapy or adjuvant chemoradiation. In adjuvant chemoradiation, the justification for that will be that I'm able to identify which part of the resection margin is involved. So if there is a proper surgical report which mentioned that the closed margins could be at the level of exact either vein or artery, then I can identify this margin at the scans afterwards. We discuss also the extent of lymphadenectomy. If the lymphadenectomy was rather not performed or was poorly resected, then we look more for chemoradiation than for chemotherapy. But typical patient ends up with adjuvant capecitabine for half a year and further follow-up.
I would love to hear other comments too.
Can I?
Yes, sure.
I think the real question is when in intrahepatic cholangiocarcinoma is it really radically resected or resectable, because the anatomy of liver with artery or vein is a real problem for the surgery in this time. And when it's rejected, I think the data from BILCAP are at this time consolidated, and I don't think there are people or oncologists that do not use this approach for adjuvant. We need to discuss in a multidisciplinary team when we use associated the chemoradiation with radiotherapy or stereotactic radiotherapy. We can discuss it about this. At this time, I don't think there is no chance for not use capecitabine in adjuvant setting when really resected and when really era R0 resection.
Dr. Pires, and how often you go for a resection in R1s? And what are the main considerations you are taking when taking the patient back to the operation room? Or maybe you are seen as a second opinion. What would be a comment as a surgeon?
Okay. As a surgeon, we always look for an R0 resection. So it's always very frustrating when we end up with a R1 resection. I have a very similar view as Dr. Lucien. Re-resection has very little space in our daily practice. Most often when we have a R1 patient, it's because it's indeed an irresectable tumor. It's not possible to extend it in a second operation. Very, very unusual to have this patient in the operating room again. But of course, sometimes when it comes for a second opinion or something like that, always can consider that, but I don't see these patients very often in the office, and we most often go through systemic chemotherapy, and some very particular cases can consider radiation in the margins, but the mainstream of the treatment would be systemic therapy for sure.
Mm-hmm. Thank you. I guess everyone's opinion is kind of the same, and how you will sequence the treatment approaches in these scenarios. So would it be around the same when we have closed margins, or you would just prefer the chemoradiation, or what will be your considerations here? If it's R0 but closed margins.
Well, again, which margin? Because if you are a clinical oncologist in patients, either R1 resector or closed margins, we do control scan, and sometimes in that control scan you already see the disease, that it was not that great resection as we all believed. Margin as a possibility of R1 resection, there is more data from intrahepatic cholangiocarcinoma that these margins should be quite wide. Like 5 millimeters is sometimes even not enough. We observe the local relapse in 5 millimeters of clear margins, and local relapse is there. In terms of the perikilar or gallbladder, then the margins are not as easy to be assessed, because many relapses are coming from the not resected nodes, which were involved initially. So margins can be wide, but still the local relapse can be there. So I must tell you that our practice for adjuvant therapy is really based on case by case. There is quite old now, but still valid meta-analysis by Horban, published in 2012, which indicated that the role of radiotherapy is probably underestimated. They assessed that odd ratio for relapse in node positive, but clear margin, but node positive, was around hazard ratio of 0.5 if you use radiation. It goes down to 0.3 in R1 resected, so very, very high efficacy. But unfortunately, this meta-analysis was performed mostly on the series of cases rather than based on the randomized data. There was such analysis in BILCAP, which has showed that R1 resections are leading to very high risk of local relapse, but there was no analysis like that for close margins. So most of close margins will be treated as they are when they are R0 resected. But in some cases, if you know how to do chemoradiation, then you can ask your clinical oncologist to do it.
Thank you for your comments. Would you like to add, Dr. Giuseppe?
I am completely agree with Lucian this time, because on the close margin or R1 margin, the difference is important. R1 margin is similar to a metastatic. We need to expect a relapse with or without adjuvant treatment in 1 year. And at this time, I think radiotherapy could give us a big help to extend the disease-free survival or relapse-free survival of our patients. So this is the patients to discuss in MDT. So we can use all the our armamentario to treat these patients. And just on my consolidated data from BILCAP. Yeah, okay, consolidated, but we need other BILP. Only capecitabine, I don't think is the real treatment. We need more also to do for these patients, but at this time we have only for data from pembrolizumab, I think, associated with treatment in adjuvant settings, and we need to do some more help, some more for these patients.
Yes, well, immunotherapy as after adjuvant is becoming more in other cancer types. Here we don't have a lot of data yet, possibly, but as we see the benefit in metastatics, as in other cancers, it's becoming more and more early. So maybe the things will change with these two, but indeed completely agree that local control is as important as systemic control in this disease. So we have to be curious about how we define close margins and R1 resection. I believe the right diagnosis and the right having everything discussed with all the team is the first and key for the successful treatment. So thanks for these insights. Maybe we can speak a bit also more. I know that you have shared what is available in your countries, what is not, but from the latest approvals, now we have a lot of new HER2s, first-line immunotherapy, and second-line coming, and also FGFR inhibitors. What do you think were the most change-making in treating gallbladder and bile duct cancers? Which of the latest approvals changed most your practice, and what is available in your country and what is not, maybe only on the trials and research teams?
In Italy, as I have said, is available only ivosidenib and pemigatinib. We don't have zanidatamab, we don't have trastuzumab. No, we have larotrectinib or entrectinib for NTRK fused patients. But at this time, only immunotherapy in first line, durvalumab or pembrolizumab, and no other. We need some other, but at this moment only ivosidenib and pemigatinib. And this is a real problem for all people, because if I do NGS and if I find an alteration and I know there is a drug to help my patient in my country, at this moment I can choose only in clinical trial, but a clinical trial could be comport a travel of these patients from my city to another city in Italy, and Italy is not a small time.
Yeah, indeed.
So in general, we have the same, but there is a special program which is designed for case-by-case clinical decisions. So we apply for that program, and the drugs are reimbursed. There is a minor problem because when I asked for zanidatamab, then I found that there was no retailer for that, since it's not reimbursed. So we tried to apply for the program. They said yes, but give us the price quotation, and found, well, the drug is not on the market. So if it's not on the market, then we couldn't find a retailer which was ready to send us the drug. So we asked for, at that time, a combination of pertuzumab and trastuzumab, which is still not labeled in this indication, and since it's not labeled, it's not reimbursed, but we could go to this case-by-case program. This program is not easily if you have big volume diseases, because then you will have lots of paperwork. But in this situation that you start with NGS, you find a very rare mutation which is druggable, then you can apply for that. So this is the way how we are doing this at National Cancer Center in Warsaw. But for smaller hospitals, what they do, they send the patient to us, and okay, maybe you have tried, maybe you will find it out how to do it. So probably we see more patients with these rare subtypes than they are typically seen, but we are referred with those.
So deruxtecan is also not approved, even if you found.
Well, it's approved and available for gastric cancer, for breast cancer, but not for HER2 all comers, let's say. But if any drug is approved, then there is zero copayment. So this is the way how it works. That it needs to be assessed by the care authorities, because on the end of the day, patients get the drug for free. So the public proceedings for granting the approval are usually long, but on the end is very beneficial for the patient.
Oh, very interesting to hear. I guess with public and private insurance systems, as we have in Brazil, would be some kind of this scenario. Private will have a lot of drugs while public will not. How is it in there?
Yes, exactly that. In the private system, the access is very similar to other countries. So we have durvalumab, we have ivosidenib. We have some difficulties maybe in some approvals that involve higher cost drugs, maybe like FGFR2. I think it's a little bit sometimes difficulty, but maybe these problems medical oncologists here will be more aware than me. But in the public system, we have to rely only on traditional chemotherapy. So there is a big effort by the medical community to get immunotherapy into the public system, at least the ones that are we have more data on the efficacy. So I think for the next years maybe you have some changes, but it's always tough. It's we are a developing country, so have to see exactly how to use the money. So it's not easy to get the government to get to these approvals.
Yes, well, these parts of panels, whenever we do this congress on how I treat cancers on different cancer types, during the panel, we try to ask different countries to be represented and see what is actually working. Because at first, we share the trial data, we see how much is the benefit, the OS change, the PFS change with this month, there is this kind of response rate and so on. But at the end of the day, we want to know actually what we do in the clinic when a patient comes to you. And it seems that even though some countries are rich countries, some are poorer countries, but everyone has the problems because new drugs are very expensive and the new combinations are becoming more and more. And maybe this patient is eligible for receiving the treatment and not being resected, but because we cannot give the drug, we are taking him to the operating room sometimes because this is what we need to, and every country needs to tailor on their needs. So that's why we wanted this representation, and thanks for sharing your insights. From our point, I can see similarities and differences as well. I live and practice in Armenia. I like the private and public systems here. So whatever is not approved and the government is not reimbursing, so the FGFR inhibitors, even if axitinib is not reimbursed here, if the patient is able to buy, we can prescribe. This is a very interesting and difficult scenario because whenever you're prescribing a very expensive drug, which they're going to sell the house to buy, you want to be a bit more sure that this drug is going to help to prescribe this. So it's interesting to see how you navigate the challenges which you face also in the daily practice. But clinical trials sometimes in these scenarios are a solution for some patients, despite these logistic issues, traveling to big cities, because mostly big centers are having the one. Which are the novel trials or the novel data that you are most awaiting for? Or how do you see the treatment going like in 5 years? What do you think will change? What do you think will remain? Or what we are going to do? Maybe liquid biopsies, everyone. I don't know. What would be your insight? So we'd love to hear everyone's perspective on different kinds. This is not a strict question. Whatever you think that will change, let's share.
So we already completed the acquiring the patients to the big global adjuvant study with immunotherapy and local chemotherapy. So whatever chemo you are using, so keep immuno on top. And probably we need to wait 1 or more 2 years to see the results. And before we get these results, probably no one will redo such global study because it was really painful to find something like 1,000 patients for adjuvant treatment globally for phase 3 study. These biomarker-driven studies were already performed in refractory settings, so second, third line, etc. As far as I'm concerned, the studies will start to be developed in first line, so like anti-HER2 treatments will be investigated. At that time, in 2-3 years, we will know what is the value versus standard chemoimmunotherapy which we are using nowadays. There is excellent academic study by ABC Group, which is set at the maintenance for the after first line. So if the patient is having a molecular alteration which is druggable, should we continue first line or switch at the maintenance to the targeted agent? And probably these three ideas, I mean, the adjuvant immunotherapy, targeted agents at first line, or targeted agents at the maintenance at the first line. These are the most hot topics which I'm looking forward.
Thanks.
As for me as a surgeon, I'm very looking forward to some data on neoadjuvant therapy for resectable patients and borderline resectable patients, and also some new data on liver transplant setting, like which patients would benefit from immunotherapy in the pre-transplant setting, and exactly how to deal with immunotherapy and risk of early rejection, and how to navigate this. So I think this is a very promising area, but still lacks some more robust data. And I believe in 5 years, maybe we will be in a very different scenario.
But from the oncology, I think the idea of Dr. Pires, it's more interesting, and the same time it's interesting the idea of Lucian. So I need the result of all such idea near adjuvant setting and maintenance, because if we have a neoadjuvant treatment, we can do more resected people to give more disease-free survival, more people to have the disease-free survival, more disease-free survival. And in the metastatic setting, if I could maintain with a drug directed against a mutation, I could have much chances of have overall survival and progression-free survival. So I like all the idea of my colleagues, and I expect a great result from all the idea.
Hopefully the next time we gather together again, we'll have more results on the new data. It will be in 2 years, 3 years, or 5. And as we learn from bigger, for less rare cancers, we may say, like lung cancer, breast cancer, how they're doing the maintenance things. I think it's very important to know this for rare cancers too. And as you mentioned, even having trials for these cancers is difficult, because recruiting 1,000 patients with these very strict criteria is a challenge. It will be very easy to do for lung cancer, but not that easy to do for biliary tract cancers. So this is another challenge facing these type of cancers too. But hopefully we'll see the benefit. And also maybe we'll check in between with the liquid biopsies, resistant mutations. So will be the switching role even more like we do for the breast cancer as newer data come. So integrating all of those things together, we will know better how to sequence, because it's not only the using the drug, but also how to sequence. So we get the best of overall survival, not just the progression-free survivals. And we really have to learn how to manage toxicities too. As mentioned, liver transplant I'm sorry, not liver. It could be an option for a lot of patients, but with this novel era of immunotherapy, how to use them, should we use it before, and how early to start, what is the rate of the rejections, as we're learning from the other cancers too. It might be very good theoretically, but how to do and how to manage toxicities would be another issue. So big teams should work and should share their experience in doing this, because not all of the clinic will be able to do this, despite this might be an option. So expertise should be collected. And just for the last general question, do you think these kind of cancers should be centralized, like Dr. Lucian shared that they're from small hospitals, they're referring to bigger hospitals? Do you agree with this approach, or do you think that small hospitals should also take care of this kind of patients? Or how is in your countries these things done? Are they referring to you, or what is the experience?
In poor ECOG, or in case of the patient who already underwent NGS and is in metastatic disease with no targetable alterations, the patients can in any site actually. If the patient has rare subtype or is like what we are doing in Warsaw, we are running a program of neoadjuvant chemoradiation before liver transplantation in locally advanced. If the patient needs to go to such service, then you need to centralize it.
Here in Brazil, we have some specialized hospitals both in public and private settings, but it's not very clear for the patient like where to go, and despite you have a specialized center, small centers are able to perform big surgeries if they want to, and to treat the patients as they like. So I think it would be nice here for us to have things a little bit more centralized, not that you could do things just in one place. We are a very big country and have huge cities with million people. So this is a problem for us. This is a rare disease, so patients are being treated in very different conditions and under very different protocols. So this is a challenge here. How to face and how to face this situation and work this a little bit better. But I think a little bit more centralization for us here would be nice.
In my country, we have an oncological net to reduce the difference between a small hospital and big hospital. So we can offer to the patient the multidisciplinary evaluation from a surgery with a great volume of treatment on this kind of surgery, and we address the patient to this surgery, because I think the real problem is in this case is the quality of surgery. Not all surgery can treat biliary tract cancer, because it is a particular and a real complicated kind of surgery, and I think we need a surgery with a lot of experience in this treatment. So the oncological net could help us to reduce this difference and give the patients the major opportunity of best treatment.
Yes, thanks a lot. I see there are some differences but also similarities. But indeed, for rare cancers, having centralization has its role, because big center, big volume, more expertise, but also the small hospitals shouldn't suffer. So if you can see that this is a surgery kind of, or a treatment that can be performed in a small one, you can do that. But for rare cases, should be done something to be referred to the bigger hospital with bigger volume, maybe with more clinical trials. So as you mentioned, the patient situation is crucial to deciding on how to refer them further. Thank you everyone for joining us today. If you have any further comments, we would love to hear that.
I would just get back to the other topic we were discussing, like future changes that we're expecting. I don't know if any of the colleagues attended last year cholangiocarcinoma foundation meeting in the United States. It was very interesting. I was there in Salt Lake City. And the topic, the main topic of the conference was to define the most needed and the hot topic to be addressed in research for the next 10 years. So there were 2 days of discussion only about this, and they were supposed to publish this material on what would be the guidelines, what would be their, and they are nowadays the most important funding for research in the United States. So it's a big foundation, and what they do really matter that. So I haven't seen the published material, but the discussions there were very, very interesting. So for us to know what may be coming for the next years, we had a nice material there.
We'll make sure to look through it too. I haven't seen the published data yet. Maybe they have not published it yet, but as we identify different problems, we can join the forces to work on the same problems. And I think this is the core idea. And what is important with the foundations, yes, indeed, Cholangiocarcinoma Foundation is very actively involved and involving also patient advocates in these scenarios, because they also should be central part of the discussion on understanding the needs. Maybe we find a great treatment with 6 different drugs, but they are completely intolerable, and the patient advocate should be there too. Hopefully by the next panel discussion, thanks for mentioning it, we will try to involve a patient advocate too, because their voice matters at the end the most, because at the end we are discussing with the patient what they would love to do with the experience we have and with the results we might offer to them. So the future is interesting and bright. We are seeing more and more better data coming. We're not there for the results of DMMR rectal cancers, but hopefully we'll find something for bile duct cancers as well, and with the involvement of all of the disciplines involved in the treatment of these cancers. Thanks a lot for joining us today. It was absolute pleasure having you with us and listening to your insights, how you do and deal in your daily practice with these difficult cancers. And I believe a lot of us saw motivation and also saw that they are not alone in what they are doing. And by the next time we meet, hopefully we'll have even more trials and more data to discuss, and that we have changed from this to this, and now we can offer this. Thanks so much for being with us today.
Thank you.
Thank you.
Thank you, everyone.
Thank you, everyone, for joining us today. Our session is coming to end, and by the end of this panel discussion, we are coming to the closing scene of our edition of How I Treat Gallbladder and Bile Duct Cancer in 2026, dedicated for the Gallbladder Cancer Awareness Month in February. I genuinely thank all of the speakers who joined us and shared their expertise in the field of their expertise, all the medical oncologists, radiation oncologists, and surgical oncologists who dedicated their time and effort to join us and to be with us with their presentations and being part of a panel discussion. It was an absolute pleasure for me and our team to have you, and we are so much looking forward to welcoming new experts in the other fields of oncology dedicated to the new awareness month that is coming. I also thank all of my team who were behind the scenes and who made this summit a reality. All the time they dedicated to make this happen. This was it. Thank you so much, and see you next month.